Good evening, everyone. I'm Neil Love from Research to Practice, and welcome to Video Consensus or Controversy, as tonight we talk about the management of non-small cell lung cancer. We have a great faculty up here on the stage. From the far side of the podium, Dr. John Heymach, Dr. Helena Yu, Dr. Corey Langer, Dr. David Spigel, Dr. Eddie Garon, and Dr. Ticiana Leal. We also have three other faculty members who are going to appear here virtually, and I'll tell you that the format that we're about to use tonight is something we haven't done before. We like to look at ourselves as CME investigators, and we're always looking to do things differently. But I sat down over the last few weeks with Dr. Matt Gubins, Dr. Melissa Johnson, David's colleague at Sarah Cannon, and Dr. Jeruska Naidu, and really did an interview with each one of them, asking them the kinds of questions we always ask investigators, which is, what are you doing in your practice? How do you make decisions? Particularly the kinds of questions that we know general medical oncologists ask these investigators. So we like to do more than just anecdotally go beyond the guidelines. The guidelines will present a number of treatment options, but what we want to find out is, what are people actually doing in their practice? So I met with these three investigators. We recorded an interview where I went through a number of questions and actually modified the survey that I did with them. And then we gave the survey to our faculty tonight. So what you're going to see here tonight is just a snippet. We've been very interested in so-called short-form video over the last 3 years since the pandemic came about and people started using teleconferencing. We actually produced 76 videos coming out of these three interviews. We're going to experiment with how we can use these in future CME programs. But we're going to use some of that content tonight to get the reactions of the faculty on the stage to what these investigators initially said. And you'll see a graphic showing with the rest of the faculty and hopefully give you a little bit of a feel of how people are approaching clinical decision-making outside a protocol setting, understanding that, of course, people, like everyone in practice, try to individualize it to the patient. And this is really where we're heading. Each of the faculty will be giving a short talk summarizing some of the data on these on the topic that we've been given. But for each one of these, this is kind of going to be a meeting within a meeting. So on the one hand, you're going to see 6 presentations, but on the other hand, prior to each presentation, we're going to show you some of these short-form videos and really just talk about taking care of patients. So in a minute, John is going to talk about the rapidly accumulating data on immunotherapy in the localized non-small cell setting, both neoadjuvant as well as adjuvant. But we wanted to first get a few of the comments from the investigators. And before we sort of dive into neoadjuvant adjuvant therapy, one comment related to chemotherapy shortage. This is a theme through the whole weekend. We were talking about it this afternoon in terms of carboplatin, which of course is relevant here tonight. Here's Dr. Johnson.
One thing you can bring up is the carboplatin shortage. You know, right now we're struggling to figure out, okay, do you give cisplatin instead? Do you hold the drug instead and just give the Taxol with the radiation? Like we have 50 vials of carboplatin left in our practice today.
So, John, any thoughts about this? I'm guessing maybe this is not a problem for you, but for a lot of the colleagues in the community. We did a survey of 75 general oncologists that were presenting at a number of these meetings we presented today. Every single one of them brought up this issue. Any recommendations for people, for example, who can't get a hold of carboplatin?
Yeah, well, you know, so first of all, it's obviously the most common drug we're using in lung cancer. The first thing that's reassuring is in most of the studies nowadays, you can substitute cisplatin for carboplatin. There's some difference in tolerability. But when we look at immunotherapy combinations, if anything, cisplatin is tended to, you can see a little bit more benefit. So, you know, I feel good that you can substitute cisplatin. And what I'll do sometimes is turn down the dosage a little bit, especially for people who are elderly. You know, the other thing is with immunotherapy, we have good regimens, you know, like PD-1 CTLA-4 combos, like ipi-nivo, you can use without chemo. So those are the two different directions that we go in, is either cis or go chemo-free.
So a lot of these topics is really just going to be a tasting menu tonight. We're just going to give you a couple of a little bit of input. But I did want to ask you, Helena, because we said, what about, and we're going to show graphics like these, which are related to the videos. We asked the faculty about this question. Helena, you said you would use the carbo-pembro approach without the carbo, but right underneath you, Matt Gubin said he thinks about ipi-nivo, which John just mentioned. Any thoughts, Helena?
Yeah, I mean, I think that the carboplatin shortage is also dynamic, where it really does seem like there's availability, there might not be. So I think a lot of my metastatic patients aren't cisplatin eligible. I would do that if there was someone fit enough, but I think if not cis eligible, I would continue on, but with the pemi-pembro.
So let's dive in, though, to the issue of localized non-small cell and the issue of immunotherapy. Corey, in a second, I'm going to ask you to comment on these thoughts about that topic.
I think, obviously, the neoadjuvant approach has completely turned resectable on its head. I think most of the data so far are in support of this approach in stage 3. I think the data are compelling in both stage 2 and stage 3. I'm not as convinced with the 1Bs. I think the other question is there application for stage 3B, or even, taking it even further, oligometastatic disease?
I've got a lady right now. She's T4N0, huge left upper lobe mass, 7 centimeters. And so in our tumor board, we talked about the fact that she was very close to being a Pankos tumor, and how the neoadjuvant data doesn't quite extend to Pankos. Should we be treating her with chemo radiation followed by surgery, or chemo immuno? It was the radiation oncologist that said, well, what's her PD-L1 level? It was like 25%. So we are treating this lady with chemoimmunotherapy, squamous cancer, and we'll see.
So before we get to Melissa's case, any thoughts in general, Corey? We're going to talk about breast cancer Monday night. Incidentally, we're using the same approach with the videos on Monday night. Should be interesting. But there, triple-negative breast cancer, HER2-positive breast cancer, and in general, unless you have a really small tumor, you're getting neoadjuvant therapy. Do you think, with, of course, anti-HER therapy, for example, do you think we're moving towards that type of paradigm in non-small cell?
We may be moving toward it, but I don't think we're quite there. Certainly in our practice, we're using it fairly routinely in 3A for N2 and certainly for PD-L1 positive tumors. Our surgeons can still operate on stage 1 or 2, and it's not clear in that group until we have randomized studies whether we're going to really have a survival advantage. We do have data in melanoma, and I'm sure John's going to cover this, where neoadjuvant is clearly better than adjuvant, at least in terms of progression-free survival. The other issue is, particularly in the context of ADORA and other trials, we need to do molecular testing up front in this population so we don't inadvertently give checkpoint inhibitors to folks who have oncogenic drivers.
Yeah, that's a really good and practical point. Dave, you say if you could, you'd use it in all resectable situations. What do you think?
Yeah, I mean, I think the data have been pretty compelling across different studies. But with Corey, what ends up happening at our center, it's the ones we don't even get to see till they're resected. And then the 2s and 3s we get called about or we discuss those cases. So it'll be a shift. I think we'll end up where breast cancer is eventually, where we're doing even earlier stages or lower stages. But for now, I agree with Corey. It's probably the tougher stage 2s and 3s.
So again, actually, Eddie, maybe you can comment on Melissa's case, the patient with the big tumor, almost Pankos. Is that somebody you think about neoadjuvant therapy in general? And what about neoadjuvant IO?
So the one place, and you already sort of showed where we all come out on some of these things, and although our staging is not necessarily based this way in lung cancer, when you look at the adjuvant data, I think there is a big difference when one looks at node positive versus node negative disease. The data has been less strong in node negative disease, and that was true as well in the Checkmate 816 study that looked at nivolumab and chemotherapy. In that particular case, if we're getting into sort of a Pankos space, I probably would have been inclined to look at a chemoradiotherapy. If the PD-L1 had been 50% or greater, I might have viewed it otherwise, but I think these are very relative decisions. I don't think we have great data.
So here's another question we asked the faculty, sort of what's your ideal approach? Now we have, as Dave mentioned, several trials now. Ticiana, one of the issues with the Nevo trial was they only used it pre-op. These two other studies have used it both pre-op and post-op, one with Pembro, the other with Durva. Any thoughts on sort of what the ideal approach is? You, I guess, put here chemo Nevo. What are your thoughts about that as opposed to, including it in the adjuvant setting, particularly for people with residual disease?
So I think this is a topic that is of high interest to all of us. When we look at the CheckMate 816 data with neoadjuvant chemoimmunotherapy followed by resection with the outcomes that we're seeing, I think it's a really attractive strategy because you have limited chemoimmunotherapy with potentially good outcomes. Further immunotherapy in somebody who didn't achieve a path CR, I have concerns about that strategy. We have to learn more. The agent data looks very favorable, but I think we need to learn more about these subsets to really understand if we actually need a different approach for patients who don't achieve a path CR.
So John's also going to talk about the issue of adjuvant therapy, including anti-PD-1 agents. Corey, I'd like you to look at this next video and respond to the thought of, are there situations where you would be okay using an IO alone without chemotherapy? In what situations, if any, would you offer adjuvant IO without chemo?
Generally for PD-L1 50% or over, that's the pretty easy discussion with a patient. The data are very strong. I think for 1 to 49%, first of all, there certainly is a gradient. We've learned that in the metastatic setting. I'm willing to offer adjuvant to these patients, but I do take that gradient into consideration. I take other clinical scenarios like smoking status. And for 0%, I do discuss with patients that pembrolizumab is approved in their situation. I also acknowledge that PD-L1, as we've talked about many times before, is a very imperfect biomarker, especially when it's done on the pre-surgical small specimen. I'll have a lengthy conversation, share decision-making.
The subset analysis in the Keynote 91 data that showed that patients that got chemo did so much better than patients that didn't. I do think that there is something important about the immunogenic cell death, maybe, that is induced by the chemotherapy. So to answer your question, I don't offer to give immunotherapy without chemo. But if somebody said to me, I'm not doing chemo, I will do a year of adjuvant therapy, I wouldn't say no, but I'm not going to suggest it.
So Corey, any thoughts? How are you thinking through today the issue of adjuvant IO? How do you select the IO, and where does PD-1 fit in?
So up until very recently, of course, based on Empower 010, we only had the opportunity to use the Tezo in stage 2 and 3 PD-L1 positive. That's changed, of course, with the PEARLS trial, with Pembro. I'm pretty much aligned with Melissa. We have those trials show EFS benefit. We've yet to see OS benefit. We have a small but real, and I would argue clinically meaningful 5-6% absolute improvement in survival with platinum. I will give platinum for 4 cycles in combination and then follow with whichever immune checkpoint inhibitor seems appropriate. Obviously, Pembro has a leg up in that you can give it to earlier stage in PD-L1 negative, at least by indication. I cannot explain the apparent paradox of those data.
So, John, we also asked you all, what about a patient who's got a TPS of 0? And a lot of people are saying that they would use Pembro, which is approved, although whether there's benefit, I guess you could argue. How do you approach these patients, John?
Yeah, I mean, we have a discussion, but I would still give it. I think the benefit is clearly going to be small in the adjuvant setting, but I think the PD-L1 0 is where the neoadjuvant approach with chemo becomes even more important. We saw, when we give chemo in the neoadjuvant setting, it actually raises the PD-L1 level. So if you've got a PD-L1 negative, that's where I'd really emphasize giving the chemo, and even in the adjuvant setting for the reasons that Melissa said. So, that's really, I would be very reluctant to do PD-1 by itself in a PD-L1 negative patient.
So Ticiana, we asked also about a high TPS in the adjuvant setting. Interesting how many people say Atezo, although I think you could also say Pembro, and that's, I don't know if it's because Atezo came out first, but what are your thoughts about this in terms of choice of agent? Do you have a strong preference for Atezo? And again, would you be okay giving IO alone?
I think the data support using chemotherapy followed by immunotherapy in the studies that we've seen that led to approval of both atezo and pembrolizumab. For the PD-L1 high expressors, when you look at the Empower data, the trend for overall survival, the analysis that we saw there in terms of the survival curves really lead me to preferentially use atezolizumab. Again, like Dr. Langer was saying, I can't really explain the paradox with the PD-L1 expression and the pembrolizumab data, but I think that confusion of the PD-L1 expression in the 50% or greater leads me to preferentially use atezolizumab in this patient population, given the data that we have from Empower.
And we encourage you to look through. We even put some additional ones in the slide deck if you want to check out some of these questions. But the final issue in terms of localized disease, and I'm going to ask Helena to respond to the comments we're about to see, is the issue of consolidation durvalumab after chemoradiation for non-resectable stage 3B lung cancer. Here's the faculty comments. What's your experience in terms of getting people through a year of consolidation durvalumab?
I think probably 50 to 70% make it through the year. Patients post chemoradiation are more bronchospastic. And then if you add uncontrolled or poorly controlled COPD, which many of these patients have, on top of it, these patients have lots of complaints of shortness of breath and dyspnea.
All right, let's talk a little bit about stage 3 unresectable and patients with EGFR activating mutations.
I bet you'll find pretty good consensus that we're not offering durvalumab to those patients. But then the extended question is, what if you have the ALK-positive patient? What if you have the RET-positive patient? What if you have the MET exon 14 mutated patient? Part of the problem with osimertinib when you have progression on durvalumab is that excess pneumonitis. That's not as clear with other TKIs. So I think MET, BRAF, RET are alterations that I do generally give durvalumab for in that stage 3 unresectable setting.
So, Helena, any thoughts about the issue of, first of all, getting people through durvalumab, and then this issue of patients with targetable mutations, durvalumab or targeted therapy?
Yeah, I would say my experience might be a little higher than Melissa's. I think probably 2/3 or a little bit more than that I'm able to get through the year of durvalumab. So, and then the other question is a good one. I kind of think of sort of the never smoking associated driver mutations. So ALK, EGFR, RET, ROS1, those would be the 4 I think that I would not give durvalumab, and then I'd consider a TKI.
So, and again, here the faculty's thought on that. We asked about RET, and there's several people or a couple people who would use RET, including Helena, but most other people would use durvalumab. John, can you review some of the huge database on these issues?
Okay, well, we've already covered a lot of this topic, so I'm delighted to see so many friends here and be part of Neil's program and talk about the non-metastatic setting. And so just to remind everybody here, for adjuvant therapy, our goal is to eliminate microscopic disease. So there we're showing the primary. Now in this patient, it's a big primary in the left lower lobe, but we have to remove the whole left lung. You've still got that microscopic disease, and we're giving adjuvant to try to eliminate that. And so that's the paradigm here. Now, just remind everybody, the neoadjuvant has some potential advantages. You can shrink the tumor, so you might be able to get away with a smaller surgery. In that case, we get away with the lobe instead of a whole pneumonectomy. That happens sometimes. There are some other advantages. You can analyze the tumor to see if what you're doing is working. For patients, they often want to know, well, how do I know adjuvant therapy is helping? I was like, we just wait. We have no way to know if it's doing anything. For immunotherapy, and I don't think this is as important for targeted drugs, but you can mount a much better immune response, it seems, when the tumor is present with the draining lymph nodes. Mounting an immune response against microscopic disease is actually very challenging. And you can start treating microscopic disease earlier. Now, the downside is it takes longer to start the treatment. And there's occasionally some patients who don't make it to surgery. And just to level set, just so everybody remembers, and those of us that have been treating, chemotherapy for a couple decades, that entire time we were giving adjuvant chemotherapy, and the benefit here, hazard ratio is 0.86. there's a 5-month absolute gain in recurrence-free survival at 5 years. So we were giving relatively toxic therapy for tiny gains, but it was all we had, and we're certainly giving it. I say that because I think it's a good thing, but we'll see better and better hazard ratios, and sometimes it's easy to forget what we've done. Now, why would we want to block PD-1? Well, this is an interesting piece of work led by Don Gibbons and Limo Chen. It shows that PD-1 is what helps a cancer cell survive when it's floating around the blood so it can metastasize. Don't forget, your immune system every day is picking off these little micromets, but when a tumor expresses PD-L1, it can escape and survive. So PD-L1 is a key part for these micromets to live. And in preclinical models, and we have similar data in lung, neoadjuvant works better than adjuvant therapy if you compare them head to head. So at least in models where we can really control everything very well, you do much better with neoadjuvant therapy, mounting an immune response when the tumor is in place. So we've got a lot of different studies that look very similar. I'm just going to sort of give you the general schema. For neoadjuvant, they all look similar. Immunotherapy with checkpoint blockade, plus platinum versus platinum, then surgery, and then just best supportive care. Or the adjuvant studies, where you get surgery first, then typically platinum chemo, and then immunotherapy or not. Or what we call now the perioperative studies, where you get neoadjuvant, and then the surgery, and then the adjuvant after. Now, one thing to point out is if you're getting the perioperative, then anybody who doesn't make it to surgery or doesn't make it to immunotherapy afterwards is sort of on your books for that study. Whereas in the adjuvant studies, you're only taking the people who've made it through surgery, made it through chemo, and you're only taking the people who've made it through that gauntlet already. All right, so the first study is the Checkmate 816. This was discussed before, and I think this is really a practice-changing study. 358 patients, Nivo chemo versus chemo, then surgery. And first thing is the path CR rate, dramatically different, 24% versus 2% here. And we see EFS, the initial hazard ratio is 0.63. Now, as the data has matured, this number has been climbing upwards. So the recent data is 0.68. Because you can imagine the further away you get from that period where you got the immunotherapy, the less of an impact that's going to have over time. But still an impressive hazard ratio. Remember, chemotherapy, 0.86, and we give it all the time. Here, 0.63, and that's only 3 cycles of immunotherapy yielded those benefits, not a year of treatment. Overall survival, significantly different as well. So the FDA has approved this regimen. Now we've got the adjuvant studies, and I'll go through these pretty quickly. But for the adjuvant, we've got Empower 10. So that's atezo versus best supportive care. A key thing to keep in mind is the primary endpoint was in the PD-L1 greater than 1% in stage 2 and 3, as well as then we've got the overall group as well. And then the Pearls is a similar study with Pembro. And then we've got other ones coming, Anvil with Nivo and the BR31 with Durva. So Empower 10 is a positive study. Here is the primary endpoint of DFS in the greater than 1%, stage 2 to 3A, hazard ratio 0.66 in that group. So this is an approved regimen in the PD-L1 greater than 1%. Now, if you look at the overall group, with all PD-L1 levels, you see the hazard ratio isn't nearly as good at 0.79, about an 8.6% improvement. And here, if you look at the forest plots, you see the less than 1%, there's 0 benefit. You see that hazard ratio is right around 1. And even that 1 to 49 group, very little benefit. So the benefit is largely driven by the greater than 50%. So I believe in Europe, it's used in the greater than 50%, not in the greater than 1% for this reason. All right, and then we've got the Keynote 91 or Pearl study. And you've already heard some discussion about this because this, I think, has a paradoxical result. The first endpoint on the right was the greater than 50%, and then the left is the overall end group. And surprisingly, the greater than 50% was not a positive study. There you see the hazard ratio is 0.82, But in the overall group of 1B to 3A for all PD-L1s, it's 0.76, and that was positive. So I think this surprised us because we're very accustomed to seeing the high PD-L1 group getting more benefit. But remember, this is in purely the adjuvant setting when the tumor isn't present. So now this is approved for all settings, but you see in that greater than, we have this paradox here about that greater than 50% here. Now, what about neoadjuvant plus adjuvant? Well, we've got one study to report, AG, and the next one is Keynote 671. This is going to be presented at 8:10 tomorrow morning, so stay tuned for that. But we already know that's a positive study. And then the similar studies with the TIZO and NIVO. So here's the Aegean study. So we just heard this result at AACR. Key thing to keep in mind, this is neoadjuvant durva plus chemo, surgery, and then adjuvant durva. Primary endpoint of path CR, but also EFS by blinded independent review. And this population, unlike the Keynote 91 study here, EGFR and ALK patients were excluded in the modified ITT population. So the data we're presenting is without EGFR and ALK patients, and that's because in the course of the study, ADORA came out, it became clear that immunotherapy was not the optimum therapy for these patients. So this is a positive study. It achieved the primary endpoint of improved EFS, and it did this at the first interim analysis. At this point, only 31%, it was only 31% mature in terms of censoring for patients still on ongoing therapy. Hazard ratio is 0.68, and if you look at the median EFS, it's 25.9 in the placebo. It's not reached in the durva arm. The 2-year EFS rate is improved by 11%, 53 versus 64% there. And benefit was broadly seen. I think some points to note here, similar benefit in regardless of age, regardless of race. Females seem to get a smaller benefit here numerically, but it was a small group with wide confidence intervals, only 29%. Benefit regardless of disease stage here. And then I think what was reassuring here is we saw a very clear correlation between PD-L1 and benefit. So if you look at the hazard ratio in the PD-L1 greater than 50%, clearly larger, but there was still substantial benefit in the PD-L1 less than 1% with a hazard ratio of 0.76. Now remember, in the adjuvant setting, there was zero benefit to adjuvant immunotherapy, at least in the EMPOWER-10 study. But here we see a substantial benefit even in the PD-L1 negatives. Response rate also significantly improved in terms of pathologic complete response, or MPR. So it achieved this endpoint as well. And safety, there was no increase in grade 3-4 toxicity if you look at overall events or those that were attributable to therapy. So actually, the rate of grade 3-4 tox was actually a little bit lower in the durva arm. And I'm not showing the data, but the rate of R0 resection actually went up in the durva arm there as well. So this is the Keynote 71 study, the same design but with Pembro, although note that this didn't exclude the EGFR and ALK. We'll see the results tomorrow, but we got the press announcement that a statistically significant improvement was seen with no new safety signals. So we look forward to seeing this study as well.
We're going to move on to the next module, but first I want to ask Corey, interesting question from the audience from Basim. Quote, our surgeons are noticing a more robust inflammatory response if we give IO pre-op, making surgery more difficult. Does the faculty know anything about that? Is that sort of in their mind, or do you think, it looks like the data suggests to me from what I've seen, you don't see more issues at surgery. Corey, what are you seeing in your are your surgeons commenting about that?
So it's interesting, our surgeons have evolved. Initially, they were fearful of operating. And these folks worried about increased fibrosis and inflammation. Now that they've had experience, they've become converts. And certainly when you look at the raw data, the resection rates are just as good. And frankly, pneumonectomy rates in the 816 trial were a little bit lower. So that's not an issue. And of course, as already mentioned earlier, it may be better to give neoadjuvant immunotherapy. You have an intact tumor microenvironment, and the immune system may work best or be better manipulated in that way.
And, again, thinking about and breast cancer, and John M.D. Anderson, they were really leaders in this in breast cancer. Same thing. Initially, the breast surgeons had a lot of hesitation about using pre-op therapy. Now they're the greatest advocate. Well, anyhow, let's talk a little bit about EGFR and patients with both activating mutations as well as exon 20 insertions that Helena is going to talk about in her talk. It's really amazing how many oncogenic targets there are right now in non-small cell lung cancer. We're going to try to talk about as many as we can, but also maybe try to group some of these together as we were getting into this issue, for example, of unresectable stage 3. But let's start out with ADAURA. Of course, we're going to see in the plenary session on Sunday survival data. That should be very interesting to see and see how it affects people's practice. But here's what the faculty had to say about adjuvant osimertinib.
If we look at ADAURA, not all patients received chemotherapy. They're an older patient, comorbid, and I don't think they can tolerate chemotherapy. I feel okay to give them the osimertinib by itself.
For what stage disease would you offer osimertinib?
So stage 2s and 3s, I think there's no argument they should receive it. I think it's the 1Bs that are difficult. In those, I guess I would have a conversation about it. I think I would probably still prescribe it in the 1Bs because it's not chemotherapy. It is easier to take.
I think one question that's come up a couple times in clinic is, what if we identify a non-canonical mutation? Do we go ahead and prescribe the osimertinib adjuvantly?
Interesting. What do you do yourself?
I had a patient who actually is a physician himself.
Wow.
And we had a long conversation. He said, I want the 3 years of osimertinib. And we thought that was very reasonable.
Non-smoker?
Yes. They had a stage 2A disease. Compound mutation G719X and L861Q.
I think the interesting or maybe controversial topic is, really, are people giving 3 years of adjuvant osimertinib? I have not been able to do that. I have had trouble with tolerance. Maybe it's just that my N is small. In Tennessee, we don't have as many EGFR positive patients as they do in New York or Boston.
So a little bit more smokers down there. Dave, any thoughts? What about Matt's case of the non-canonical EGFR? Have you had that occur, David?
Not an early stage disease, but I agree with Matt. Certainly if my patient was a physician, but I think that makes sense.
What about the issue Melissa brought up of getting through osimertinib? I saw a couple of faculty people raising their eyebrows a little bit. But
I've been laughing because I'm happy to see Melissa and I agree on a lot of things, but I probably am a little bit different here. I think it's been a little bit easier to get folks through it, and I think the data kind of lean in that direction. The dropout rate's been pretty low on ADAURA. I think we'll see more about that. Coming up here soon, but I think that's reassuring, and that's been my experience.
And Eddie, I guess we're going to curious what your thoughts are about the survival data we're about to see, and how you think that's going to affect people. Also, do you think there are people out there not using, osimertinib or not testing? Here a lot of times people bring up this issue about what's really happening in the community setting.
Well, one thing in the community, I think there is some question as to whether testing is universal. I think certainly at academic centers we would have tested all of these people, and most practitioners do, but certainly not all. I think that the survival data, my suspicion isn't likely to change a lot of minds, because I don't think there are a lot of minds left to change. I think that most physicians and patients adopted this. There may be a little bit of a bias that we tend to be at academic centers. We tend to have a more aggressive patient population than in the community. But I think that it has been widely adopted in our groups. I think that the one thing that the survival data can change is what Melissa just pointed to, which is a lot of patients who are not willing to necessarily go through the entire 3-year duration. And although I don't know that the survival data will convince all of the patients to continue for 3 years, I think that the discussion between the physician and the patient becomes a little more pushing towards the idea of trying to treat a little bit longer now that we know that it's not just a progression-free survival benefit, but actually is associated with the survival benefit.
And Helena, again, thinking about breast cancer, we started to see increasing durations of treatment, for example, with tamoxifen. Do you think this is something that ought to be looked into in terms of osimertinib? Also, one of the things that was interesting when the ADORA data first came out is we started to see a lot of general medical oncologists saying, I'm just going to give the OC and not chemo. And there was a lot of pushback from the investigators. You've got survival data, but they're like, as John was talking about, the hazard rate for chemo is pretty minimal, not the greatest experience to go through. And I see here for stage 1B, 50%, you generally don't use chemo at this point. Any thoughts about duration of therapy and the use of OC without chemo, Helena?
Yeah, so duration of therapy, I think that's a great question. Personally, I tried to do the 3 years and I actually don't have too much trouble doing that. I feel like, for the people that, you potentially have cured, I kind of try to stop at 3 years, but I've had some patients not want to. I think for the chemotherapy, I kind of think of them separately. I think, is this patient a candidate for chemotherapy? Yes, no, do it. And then, yes, no for the osimertinib. We don't cure everyone, especially even with 1B. So I feel like anything that we can do that's additive, I would want to do for my patients.
So we thought when I talked to these three docs that FLAURA2 was going to be presented here at ASCO. It turns out it's not actually going to happen, but hopefully it will happen soon. But there is a press release out there that I think already kind of gives us an idea of what we're going to see. Ticiana, I'm going to ask you, after you hear what the faculty has to say about their thoughts before they see the FLAURA data. And this is oncology, You see a press release, it's very informative, and you're starting to think about, okay, what am I going to do once the data is out there? Here's what our faculty had to say. FLAURA2, any thoughts about whether or not that's a strategy you might want to use, and if so, in what situations?
Yeah, it's a really good question. So just a press release says PFS benefit. So, ultimately, the whole approach for EGFR-mutant is to try to avoid chemotherapy. So I think it's only going to be someone who I think is high risk. So I think what defines that?
Of course, it'll be positive enough to get an approval, but I don't think most patients in Tennessee would use it. Patients like the pill. They don't want to be coming in all the time.
When I first saw that, the first thing I was thinking about is the highly symptomatic patient.
OC is such a good drug for symptoms, pulmonary or CNS. So I think it'll have rare uptake. I love Helena Yu's investigator-initiated trial. It's for patients in the front line, EGFR-positive, getting osimertinib, and they have 3 weeks of OC. And then all the patients get a ctDNA draw. And it's based on whether they've cleared their ctDNA that they're randomized then to chemo or not.
So, Ticiana, any thoughts about what you're going to be thinking about when we eventually see these data? And Helena is going to talk a little bit about her trial, but curious about your thoughts about that strategy as well.
I think I could echo exactly what Dr. Johnson said. I think I'm looking forward to seeing the results and the magnitude of benefit within the results of improved PFS. However, again, I don't think it's going to be a widely adopted strategy. We're really going to have to look at the subsets. I would favor using it in high-risk patients and would be really interested in seeing the ctDNA data that hopefully they'll have. But I think it'll be for selected patients if it gets approved.
I also asked them about other issues related to EGFR-mutant disease, and here's what they had to say. If you could give amivantamab and lazertinib or amivantamab plus osimertinib, would you?
Yes, I'm very impressed with those data. I know they are early, the Chrysalis studies. I think if I had access to it, I would certainly try it because it's avoiding chemotherapy in that circumstance.
How about patritumab?
Patritumab deruxtecan, I think, is also exciting, shows similar efficacy in this population. I don't think so far as exciting as amivantamab lazertinib. I think I would probably still go with old-fashioned platinum doublet over that so far and go third line with that.
In what situations, if any, do you continue osimertinib on progression when you add something else in?
Certainly anybody that's got CNS disease, I do.
For how long?
I really prefer to keep it going. I'll let them dose reduce to 40 during chemo and then raise it back up to 80.
So, Eddie, of course, we're talking about the patient who starts out for metastatic disease on osimertinib, responds, and then progresses. Curious about your approach. Do you, most people are getting at least a liquid biopsy. How hard do you push for tissue? What do you think about these new strategies? Theoretically, I don't know if you've ever given amivantamab and osimertinib. What do you think about amivantamab and lazertinib, and also the antibody-drug conjugate patritumab?
Sure. So we often do try and get, at least I try and get a liquid biopsy in patients at the time of progression. But I think we, as academics, sort of oversell this data. The best we can generally find is a secondary resistance mutation that gives us sort of a vague idea about how we might want to treat the patient with combinations that we don't really have great safety or efficacy data on. So although I do try to get it, I have not always pushed as hard as some of the people probably on the panel for for a tissue biopsy. I think that the patritumab and the amivantamab, lazertinib studies are interesting, but I really do want to see what those look like in larger studies. I think that I'm not ready to adopt those yet until I see more data, and I guess the FDA will prevent me from doing that anyway. But I don't think it's slam dunk that these things will take over in this setting, and I'd like to see the data.
John, I see you have a comment, but also can you comment on this issue of continuing OC on progression?
Yeah, it's a great point. And, I tell people in the beginning, they say, what if it starts growing? Well, I say there's two different ways you can think about it growing. One is oligoprogression, where you've got a bone met or you've got a slowly growing lesion. The other is you show up and all of a sudden there's 20 liver mets or something like that. In the latter case, you've really lost control. And there I really am switching to a different systemic option. But in the former, we'll be pretty aggressive at trying to consolidate 1, 2, or 3 lesions. Xining Li led an analysis of patients where we did continuation of OC after one of these local measures. And patients often got more than a year just by hitting a lesion or two and then continuing it. And the patients really enjoy continuing it. But for patients, if you've lost systemic control, I think both the patritumab and the lazertinib data both look solid. The PFS is not tremendously long for those, but I think they both look solid. I try to continue first, but if you've really lost control, I think those are both very reasonable options.
So, Corey, before you comment, I'd like you to look at the faculty's comment about their approach to metastatic disease with exon 20 insertions, or you can comment about this progression issue. Also, exon 20, here's what the faculty had to say. Metastatic exon 20 insertion, first-line therapy.
So for first-line therapy, still giving chemo IO. So amivantamab or mobo in second line.
I would be willing to offer them in either sequence. I find just mostly for logistical reasons, most patients, given the choice, would rather start with the mobocertinib, just being an oral compound. Amivantamab and take up the third place. Again, not for efficacy reasons, more just because patients would want to push off as long as they can that weekly infusion and then biweekly infusions to follow. It's a little bit onerous. I would ask if anyone has tried to bring those to first line in an off-label way, absent reimbursement and, regulatory issues. We certainly have a principle of leading with our best foot forward. Are these good enough feet that it's been promoted to first line for some of our colleagues?
So, Corey, you had a comment about progression on OC, and then I'm curious about your thoughts on sequencing of therapy in metastatic disease in exon 20.
So I'll start with the latter since we just heard commentary. For exon 20, I start with chemo first, generally PEM-carbo plus or minus Bev.
IO? IO?
No IO in that group. Again, because it's EGFR, though you can make an argument. On occasion I've done it, but in general, off study not. And then I've used amivantamab. I just find it less toxic, believe it or not. Mobo is a tough drug. I don't know anybody can get full dose. Maybe David does, but I do not. And then getting to progression, I think it's very important, at least in the common sensitizing mutations, that you look at the pace of progression. If it's very rapid, you need to do a biopsy and rule out small cell transformation. I don't know if we've really mentioned that. And those numbers may be going higher in the OC era. I've seen at least 3 or 4 in the last year. always get both tissue and liquid biopsy. It's 2 shots on goal in terms of molecular analysis, and that'll certainly inform your therapeutic decision making. And if it's smoldering, sure, continue the OC. If it's isolated, continue the OC and use some local modality. And for those who've done really well and have a single site of residual disease, increasingly we are adopting the approach that John had talked about with ablating or surgerizing the remaining lesion.
So Dave, any comments about which targeted therapy you use first? It's interesting, and we see this in general when we ask people this. You may ask 2 people, they give you completely different experiences. You can look at all the data you want, but it's a lot of times it's what you've experienced. So Matt, uses MOBO, and the entire faculty, nobody else does that. Everybody starts as AMI. What's your experience with tolerability with both of those approaches?
I just last week I saw a young woman who progressed with an exon 20 insertion on chemo, and we had this long discussion about trials, and of course MOBO and AMI. And she said, "Well, what do you want me to do?" And so I said, "Let me see if we have a trial available. We'll probably try MOBO first, and then meet me this week." Or when I get back next week. So I really, it's a toss-up. AMI, the problem I have with AMI is just the nurses I work with. It can be tough in the treatment room. I mean, almost everybody has an infusion reaction. There's some hope that that'll change in the future with maybe some formulation issues or a way of administering it, and that could be a big game changer for the preference that I would make with those 2 drugs.
So much data to go through tonight, but this whole weekend in oncology in general, just exploding with data, exploding with new agents. What a challenge it is to be a general medical oncologist nowadays. Helena, we asked you to just summarize some of the huge database of these clinical situations.
Sure. Hi, everyone. Okay, here's what we'll try to go over in 8 minutes. So for early stage disease, I think everyone has heard this again and again, but ADAURA, randomized study for stage 1B, 2, 3. They only included the common canonical exon 19 and L858R, randomized 1:1 to 3 years of osimertinib versus placebo. We saw the DFS data probably now almost 3 years ago with the approval, the FDA approval. So these are the initial DFS curves looking at the all-comers, 1B to 3A, and the 2 to 3A. You can see marked improvement in DFS with osimertinib. There was updated data at ESMO last year with longer follow-up with a continued hazard ratio DFS benefit of 0.23 in all-comers. And thinking that the benefit does deepen with higher stage, but remained across stages, all subgroups with or without adjuvant chemotherapy. So this is, I think, standard of care. We'll see the OS data, which we heard was statistically significant and clinically meaningful. So we'll see what that holds. CNS recurrence was also, we know that osimertinib is very CNS penetrant, so there was a significant decrease in CNS recurrence on ADAURA as well. So for first-line treatment, I think that the FLORA study really established osimertinib as best-in-class, single-agent EGFR TKI in the first-line setting, improvement in PFS and OS over earlier generation EGFR TKIs. But despite this, PFS and OS are still relatively short for this population, and so lots of interest in combinations in the first-line setting. I think what's really important to note in this population, so 50% of patients with EGFR-mutant lung cancer will ultimately develop brain metastases, so understanding the different therapeutic agents and their CNS efficacy really is critical. FLORA did not mandate interval MRIs, but we know the rate of symptomatic CNS progression was 3 times lower with osimertinib compared to earlier generation TKIs. But just a plug to say that really new therapies must include routine CNS imaging because this really is an important factor for clinician and patient choice of drugs. And so thinking about what can we combine with osimertinib in the first-line setting. So one potential option are VEGF inhibitors. So erlotinib and bevacizumab have been looked at in multiple phase 2-3 studies. Clear PFS benefit, no survival benefit. There's approval kind of globally selectively for this. Erlotinib and ramucirumab were also looked at in a phase 3 study, improved PFS, no OS data, US approval. We did a phase 1 study of osimertinib and bevacizumab that showed good safety, feasibility of giving both drugs at full doses. I have the schema on the bottom left of EA 5182, which is a randomized study looking at osimertinib plus minus bevacizumab. And I think what is important about this study is it is mandating CNS interval imaging for all patients. So we'll be able to see CNS efficacy, and hopefully this will be kind of a definitive study to decide whether there is a benefit of adding VEGF to osimertinib. So the other possible thing to combine with osimertinib is, of course, chemotherapy. What's different about chemotherapy, though, is, of course, it is effective on its own, so you're combining two separately active treatments. There are two seminal studies that looked at chemotherapy with gefitinib out of India and Japan. Both of them showed marked benefit in PFS, but more questionable benefit with OS. So we just saw NEJ-009 updated data where overall survival was not significant. And then Neil mentioned the FLAURA2 study, where we did get the press release statistically significant, clinically meaningful improvement in PFS, and we'll see sort of the data there. I think the thing to think about is when we combine two active therapies, there needs to be a clear improvement in PFS more than the sum of sequencing or a survival benefit. So understanding how much PFS benefit and whether there's an OS benefit are really paramount. I think the idea being, if we combine two active treatments, we might better eradicate those persister cells that lead eventually to resistant disease. I think that we mentioned the work that we're doing here. I think that we really need to personalize therapy based on a patient's risk. My goal is not to give osimertinib to everyone. My thought is to use some kind of biomarker, whether it's EGFR mutation subtype. We know L858R and atypical mutations do worse with osimertinib, co-mutations like P53 or RB, or using EGFR ctDNA clearance. But I envision low-risk patients getting osimertinib alone, then maybe medium-risk osimertinib plus VEGF, and then higher-risk osimertinib with chemotherapy. So kind of personalized therapy within personalized therapy. So for mechanisms of resistance to osimertinib, I think the big key here is that it's diverse. With better on-target EGFR inhibitors like osimertinib, we're seeing more off-target resistance. Corey mentioned lineage plasticity. We see actually transformation to small cell lung cancer as well as squamous cell lung cancer, and this is in 15% of cases. There's also a poster, a multi-center poster that again corroborated that 15%. So it's a decent amount of patients. We also see potential acquired alterations as well. So kind of thinking about what we can do for on-target acquired EGFR mutations, there are new 4th-gen EGFR TKIs that are in clinical development. There is that potential to add in other targeted therapies if you happen to get one of these rare acquired alterations. For lineage plasticity, though, the tumors really are no longer dependent on EGFR signaling, and so really switching to histology-based chemotherapy is key. MET amplification, we see this in maybe 15 to 20% of cases post-osimertinib. There are a lot of MET inhibitors that have the potential to be combined with osimertinib. I'm showing waterfall plots of two of those studies, Savannah, that's looking at osimertinib and savolitinib, with a response rate of 49% in patients that are high MET expressing post-osimertinib. And then we saw osimertinib tepotinib data at ESMO last year, response rate of 50% in patients that are MET amplified. So I think if you have one of these targets, it is beneficial to utilize these combination therapies. We mentioned this already, small cell transformation, squamous cell transformation. I think the key here, outcomes are poor once the transformation occurs, so really trying to prevent transformation is paramount, and there's a lot of us working on that. I think that these sort of biomarker-based large cohort studies are going to be, or are important. As someone mentioned, these are hard to get clinical prospective data on these combinations. So here's a study where we biopsy patients, look for different targetable mechanisms of resistance, and patients are getting these osimertinib-based combinations. And then if patients don't have an identified biomarker, they're getting potential combinations like osimertinib plus a TROP2 ADC that should be potentially efficacious in all patients. All right, to kind of very quickly go over patritumab deruxtecan, this was mentioned, it's a HER3 antibody drug conjugate. This phase 1 study was looked at post-osimertinib, post-platinum doublet chemotherapy, and did demonstrate a response rate of 39%. I think what's important to note is that patients had diverse mechanisms of resistance to osimertinib, like C797, MET amplification, ALK fusions, and this did seem to be active, in all of those. And so there are bigger phase 2 studies looking at this agent. We did also talk about amivantamab and lazertinib. Amivantamab is a MET EGFR antibody. Lazertinib is a third generation EGFR TKI. Also good response rate. This was done before chemotherapy, but again, I think active drugs that might be beneficial to a lot of our patients.
We want to shift over now to move to other forms of targeted therapy that Corey is going to discuss. But before we do that, again, we want to talk a little bit about taking care of patients. We're going to start out with the issue of first-line therapy metastatic ALK. Let's talk about ALK, first-line therapy for metastatic disease.
Alectinib.
Patients who get alectinib but have difficulty tolerating it, you want to switch to something else. What would you likely switch to?
Brigatinib.
About how many times have you used brigatinib? Have you seen the pulmonary reaction?
I've only used it a handful of times. I actually enrolled patients on trial at the time, and no, I did not see the pulmonary reaction.
Patient who gets alectinib but progresses after 3 years.
Brigatinib or lorlatinib.
How do you decide between the two?
Side effect profile. I am a little nervy about the lorlatinib cognitive stuff. I don't really know what to do with it. So my bias is probably brigatinib.
I do talk about with patients that there's this opportunity to give lorlatinib in the first line, talk a little bit about the toxicity profiles. It might be interesting to ask the panelists if they at all take into consideration the ALK variant in their decision-making. So I think that this thought that maybe you might treat a variant 1 different than a variant 3.
So Corey, any thoughts? You know, it's amazing. I talk to these people all the time, how I hear things I've never heard before. Hey, good to see you. ALK variant, I hadn't heard about that.
Emerging data, not necessarily routinely reported on the molecular screening, so it hasn't influenced me yet. Certainly some suggestion that lorlatinib or other agents might be better there. You can see how all of us voted here in terms of first line.
Yeah, that's how we do a consensus. We ask somebody what they do and everybody does the same thing. We call it a consensus, so I'll call that a consensus. But it gets a little trickier once you get into these other scenarios. So patients who can't tolerate alectinib, Corey?
I haven't seen anybody not tolerate alectinib, so it's sort of a moot question. Usually you can dose reduce or do something else. And again, brigatinib, in my experience, is better tolerated than lorlatinib.
So we'll talk a little bit about RET-targeted therapy. I'm going to ask David to respond to the faculty's thoughts about that, which is the following. First-line therapy for RET fusions.
Selpercatinib.
Any reason that you prefer that over pralsetinib?
Just experience. I hear that people that know pralsetinib love it as well. Those are really clean drugs.
Coke or Pepsi? We use selpercatinib only because we were on that clinical development program, but I would feel very comfortable and have equipoise between the two, mechanistically, efficacy-wise, toxicity-wise.
A patient presents with RET and has brain mets but no CNS symptoms, either for disease that could be stereotactic or whole brain. Are you going to radiate or start systemic therapy first?
Okay, so I try to avoid whole brain at all costs. If that's the case, if there's multiple brain mets, I'll give the targeted therapy on its own and take my chances. If it's a small amount of brain disease, and I think they're quite symptomatic and would benefit from a little spot weld of an SRS, then I might do it.
Asymptomatic.
No, then I won't do it.
So, David, any thoughts about choice first line, but also this issue of brain mets? And, other cancers, including breast, look at you all in terms of the model you all really created about holding off on radiation and trying systemic therapy. So curious not only how you approach that, but what about other mutations? Will you do that with HER2 mutations? Will you do it with BRAF? When will you hold off radiation?
Yeah, well, first of all, in terms of choice, I think it's a coin flip. It's funny, Melissa chose the opposite of what I was going to say. I put no preference, but I just talked to a woman yesterday who's been on a month of pralsetinib, doing fine. So I think I like radiation in general. Okay, don't think I don't. It's something I use every week in some fashion. But I hate using it in anybody where I could do something else. And so HER2 is a different story because we don't really have good data there that says, ADCs can affect that, although in breast cancer, and you know those data better than I do, there is efficacy in the CNS. But almost every other oncogenic-driven setting, I would try that first before giving SRS, even if somebody's symptomatic.
KRAS G12C?
That's a tough one. The response rates are certainly lower, but we know there's activity with adagrasib and sotorasib in the CNS.
So speaking of having different experiences clinically, Eddie, I'd like you to respond to when I asked the faculty about their approach to ROS1.
How about ROS1, first-line therapy with and without brain mets?
I have to say, I've had trouble with entrectinib. The tolerance is not as easy in my hands as crizotinib. So while the CNS penetration is better, and I am tempted to use it if there is CNS involvement, if there's not, I've gone back to crizotinib.
We're still favoring entrectinib for either. I'm a little more enthusiastic for a patient with brain metastases, just knowing that crizotinib is less likely to be helpful in that scenario. But even on balance, I think I found entrectinib to be more tolerable than crizotinib. So absent any clear data that support crizotinib over entrectinib, I usually start with entrectinib in the first line.
Eddie, any thoughts?
Well, I think one of the things is that there aren't a lot of people who have treated 30 patients with these drugs with the ROS1, and I think that's why we tend to be highly biased by a small sample set. My preference at this point is entrectinib. I don't make the distinction between whether there are brain metastases or not at baseline because I suspect that in most cases eventually there will be brain metastases. So I have done that, but again, I think it is clearly one of those situations where because even people like us who treat specialized clinics don't see a ton of these patients, that we do tend to weigh heavily individual experiences.
That's a really good point. So Corey, we asked you to review the data related to these questions.
So this is an area where we've seen stupendous progress in the last, really just the last 5 to 7 years. First, for ALK-rearranged, again, phenotypically, these patients look very similar to those with EGFR mutation. Never minimal smokers, generally younger. Average age here is 50, almost exclusively adenocarcinoma. Slight increase of signet ring morphology. And without treatment, really poor prognosis. About 3 to 7% of all of those with non-squamous non-small cell. Stupendous results compared to our former standard of crizotinib. So if you look at the brigatinib study, a hazard ratio of 0.49 with median PFS, not survival, progression-free survival of 24 months. For the ALEX trial, hazard ratio of 0.47 with PFS coming close to 3 years. And finally, the CROWN trial for lorlatinib, that hazard ratio goes down to 0.28 with a PFS of not reached, essentially. And you can see across the board at 1 year, 70% apiece for brigatinib and alectinib, 78% free from progression. Those curves separate early. If we look at the CROWN trial with some recent updates, 3-year PFS in nearly 2/3 of patients, and I believe we're flirting with 5 or 6 years at this point. So amazing data that, let's face it, we knew none of this 10, 12 years ago. All of these drugs have CNS penetrance. They're way superior to crizotinib in this regard. For brigatinib, the hazard ratio is 0.3 in terms of CNS progression. For alectinib, that hazard ratio drops to 0.16, and for the lorlatinib in the CROWN trial, it's 0.06, with fewer than 3% of patients having CNS progression at 1 year in the randomized phase 3. If we look again at the CROWN trial, at 3 years, 92% are progression-free in the brain if they receive lorlatinib. And remember, brain is a prime location for progression in this disease. Usually within 2 to 3 years, more than half, 60, 70%, in former studies will have progression. Of those 112 without any baseline brain involvement, only 1 had progression in the brain at the 3-year mark. The problem, and we've all amplified this, is the toxicity. Cognitive mood changes. I've seen neuropathy. I have seen visual and auditory hallucinations, hypercholesterolemia, big deal. We can treat that with pills. Weight gain, edema, 17% grade 3, which means more than 20% increase. Both the weight gain and the cognitive and mood changes are really due to off-target inhibition of tropomyosin receptor kinase in the brain. And this is why most of us shied away from it. I think when we looked at the survey, virtually all of us, at least on this panel and amongst the remote folks, chose alectinib up front. Although ostensibly, if you do cross-trial comparisons, maybe lorlatinib's better. So can that apparent enhancement in PFS and CNS penetrance for lorlatinib offset its increased toxicity? Would any of us have equipoise conducting a randomized phase 3 trial of lorlatinib versus either alectinib or brigatinib? If lorlatinib is used up front, then what do you do for second line? So you've all seen these in vitro sensitivity tables for acquired resistance mutations. Brigatinib and lorlatinib really having the best IC50s, probably lorlatinib a bit better. And in the second line and previously exposed second generation ALK inhibitors, the response rate is almost 40%, PFS 7 months for lorlatinib, and intracranial responses of over 50% with a fair number of complete remissions, echoing David's point that you want to avoid radiation here if you can. What about resistance to lorlatinib following prior ALK TKIs? The majority don't have mutations, or at least an identifiable mutations on post-lorlatinib tissue biopsies. Compound mutations are seen at 29%, single mutation 19%. There doesn't seem to be any predominant compound ALK mutation. Among the 14 cases with 2 or more ALK mutations, a fair number, over half, had G1202R, and another fair number had ALK-1117. And there are new drugs coming along, such as NUV655. I call these license plate therapies. They don't have names yet. But clearly, when both mouse xenografts and patient-derived xenograft models, you see superiority versus the vehicle or lorlatinib. ROS1, about 2% of non-small cell, also found in other malignancies like brain tumors, cholangiocarcinoma, activated by chromosomal rearrangement, again, break apart FISH to identify it. No real overlap with ALK, although phenotypically these patients look very similar. Crizotinib, which I think we're sort of even on this, median PFS of 19 months, response rates of over 70%, the waterfall plots with rare exception, virtually everyone exhibiting a response. Crizotinib was approved based on these phase 2, not phase 3, but phase 2 data 7 years ago, March of 2016, and entrectinib followed 3 years later. Similar response rate, 68%, PFS close to 16 months. Again, astounding waterfall plot with a fair number of CRs. The benefit here, the advantage entrectinib has, is in CNS penetrance. Response rates are 80% in this group of 25 patients with measurable, that means at least a centimeter or larger, CNS metastasis. The median intracranial PFS over 8 months. When you look at the entire group, the time to CNS progression was not estimable. It was close to 14 months for those who had baseline CNS mets. Again, the toxicity. In my experience, sort of mirrors Melissa's, and yet Dr. Gubin said entrectinib is better tolerated. I find crizotinib somewhat better tolerated, more predictable GI toxicity, some edema, visual disturbances that seem to abate over time, entrectinib dizziness, dysgeusia, weight increase, paresthesias, again the NTRK phenomena, myositis and CPK elevations. I've also seen Achilles tendinitis and myocarditis in my experience. I've done the same thing. I'd adopted entrectinib for a bit and I've gone back to crizotinib. Other agents, again, have activity frontline. Lorlatinib, taletrectinib, repotrectinib, all with response rates that are comparable to entrectinib and crizotinib in this setting. All having CNS activity. You see intracranial responses ranging from 64% to 100%. So which agent is preferred frontline? I think it's a draw. Does the superior CNS penetrance give entrectinib a leg up? What is the optimal approach? Second line, at what point do we intervene with chemo, which in my experience is usually PEM-carbo with or without BEV? So again, you have two choices, chemo-based trials or next-generation ROS1 inhibitors. Note that mechanism resistance G2032R is about a third of patients who have had progression on crizotinib, And here, taletrectinib and repotrectinib may have a leg up again, or superior, better activity in that acquired mutation compared to lorlatinib, but still respectable response rates, 35 to 50% major CNS activity, intracranial penetrance, so half or more of patients exhibiting some benefit. Finally, RET fusions, RET tyrosine kinases play a crucial role in cell growth and differentiation. About 2% of non-small cell, a bit more common in papillary and other thyroid cancers, 10 to 20%. The loss of function leads to developmental disorders like Hirschsprung's disease and aganglionosis of the gut. And phenotypically, these patients are similar to ALK and ROS. They're younger, they're never smokers, almost always adenocarcinoma. Again, some signet ring morphology. If we look at older, what I call promiscuous TKIs like lenvatinib, cabozantinib, and vandetanib, relatively low response rates in RET, 20 to 30%, PFS of 6 months, far short of what we've come to expect, of course, with ALK inhibitors, with crizotinib and alectinib and ROS1, and of course with OC and EGFR. But now we have selective RET inhibitors, the ARROW trial looking at pralsetinib, treatment-naive patients, a response rate of 72%. Those who have been previously treated, 59%. Again, with rare exception on those waterfall plots, virtually everyone exhibiting some benefit. And selpercatinib, the libretto trial, 68% response rate overall, in the treatment-naive patients, 85%. So here's the table summarizing all those data. Again, intracranial activity, 82% response rate for selpercatinib, 70% for pralsetinib. You see in the untreated group for selpercatinib, median PFS hasn't even been reached. It's 19 months for the pretreated group. Similar, maybe slightly lower numbers for pralsetinib. A fielder's choice. Toxicity does seem to be a little bit more pronounced for pralsetinib when we look at grade 3 and 4, including hypertension, transaminitis, and some cases of pneumonitis. And I've, like most of the others, or at least some of the others, have chosen selpercatinib. Finally, ongoing phase 3 trials comparing either selpercatinib or pralsetinib to standard frontline chemo with or without pembro. These are treatment-naive patients, and then folks who've had at least no prior TKIs, but perhaps prior chemo, selpercatinib, versus older agents like cabozantinib and vandetanib, and there are new agents, TPX-0046, and the BOS1 agents that are being looked at in phase 1. So, in summary, in 10 years, a whole array of TKIs that were not even on our radar, that are highly active and have made differences in these patients' lives, major differences.
So just a few follow-up questions. We're getting some great questions from the audience. John, what's your experience with the CNS effects of lorlatinib? We've heard a lot of dramatic stories. And do you find a dose reduction abates that?
Yeah. So first of all, and Corey made this point, but the CNS activity of lorlatinib is really impressive. And I've actually had a mixed experience because I've had some patients who get a little bit giddy. They almost feel like they say like they've knocked down a cocktail or two, and they actually don't mind it at all. Other patients get sort of dysphoric and just say they're off and they're very bothered by it. And then I've got a couple who have no CNS effects whatsoever, but are bothered by the edema. And the edema for some people, is really significant. So that's why it's a mixed experience. But I've got one woman who had CNS disease that progressed on alectinib, who's been 4 years now on lorlatinib, doing spectacularly. So it really, it's a wonderful option to have it there when you need it. But I, like everybody else, start with something a little gentler in the frontline setting.
So, Ticiana, a question from the audience. Someone has a 50-year-old woman, EGFR-mutant, status post, solitary brain met, presumably removed. What about the dose of OC with brain mets, bringing up the issue of increasing the dose? Is that ever something you consider?
Not really. I don't think we have enough data that if the patient was already on OC, had a brain met, that I would increase their dose of osimertinib. Certainly in a patient like this, I would favor resection followed by focal radiotherapy to the resection bed and monitoring the brain quite closely, but I wouldn't increase the dose.
So, Eddie, we were talking earlier about the ADORA study, and again, one of the audience says, would you use a RET inhibitor in the adjuvant setting? Well-informed patient, you might have a medical oncologist as a patient. Would you offer RET, for example, a RET inhibitor in the adjuvant setting, if you could?
So I think this is a particularly difficult question. I think that we are extraordinarily reluctant to take the data that we have with osimertinib and apply it to every targeted agent in biomarker selected groups. And we have data over the years with, for instance, first generation EGFR inhibitors that have not really shown survival benefits. The one that I do find difficult in particular is RET and ALK. The data for both of them are so compelling in the metastatic setting that they look as agents similarly good, if not in the case of ALK, perhaps even better than osimertinib. So I think that obviously coverage is an issue. This is not something that would be considered standard. But certainly it is something that I think you are going to have to talk to patients about, because I certainly wouldn't think it's unreasonable to consider either in the setting of certainly of ALK and RET and maybe even ROS1 consideration of adjuvant.
Curious, David, about your thoughts, and are we ever going to see trial data?
Well, I was glad you gave Eddie the toughest question of the night, because it is hard, because we all are excited about the ADORA data. We know the press release, so we know there's a survival advantage. And immediately you go right to these other areas, and you have a patient in front of you tomorrow. And as we're walking in here, Dr. Heymach was saying, what would we do if it was one of us? We're definitely having the conversation. Whether you can get the drug or not, I think it's another question. But this is one of those situations where it may take another 5, 10, or more years to get these answers from these adjuvant studies. And is it fair to wait that long? And, I would say for some of these settings, no.
And, there's, of course, a lot of interest in involving patients in difficult decisions if they want to be involved. Corey, you had a comment?
Yeah, in the adjuvant setting, I have to confess I have given alectinib at this point. I don't know if the others would confess to similar. BRAF and MET can be quite responsive to immunotherapy. So there I do draw the line, and I would pretty much stick with either neoadjuvant or adjuvant approach with a checkpoint inhibitor.
So we're going to talk about some other forms of targeted therapy. And first, we're going to talk about HER2, which, of course, as we all know, has become an issue not just in breast cancer, lung cancer. We were talking about it this morning in upper GI cancer, colorectal cancer. We've seen an approval with HER2. So here are some comments about TDXD in non-small cell.
First-line therapy in HER2 mutant non-small cell.
This is a patient population where we have been reaching for trastuzumab deruxtecan. I do follow echocardiography as taught to us by the breast cancer colleagues. And I am on the lookout for pneumonitis. I mean, we're doing enough frequency in terms of restaging anyway that I think we capture that. And this is a patient population where I'm proactively educating them about that risk. And so they know that they would be in touch between scans if there was some decrement in their respiratory status.
And would you re-challenge a patient who had stage 1 pneumonitis?
For stage 1 that improves, I would re-challenge.
And grade 2?
Grade 2, and certainly by grade 3 might be the point where I'd say, let's abate this with steroids, let's get to resolution, but let's try another viable line of therapy. And then maybe I'd consider a re-challenge down the line if the pneumonitis was clearly resolved.
Your approach to HER2 overexpressing lung cancer, do you use TDXD, or would you like to?
I haven't, except on trial situations to date.
Do you use prophylactic antiemetics?
I certainly do. Yeah, these are patients in our protocol build. We do use ondansetron and dexamethasone pre-meds with each dose. It's chemo. It's hopefully a little bit more targeted chemo.
So, Helena, we had your colleague, Dr. Shanjigan, in here earlier today. And of course, she's taken a leadership role in the use of anti-HER therapy, particularly TDXD in upper GI cancers. What are your thoughts about Dr. Guman's approach? Would you like to use? Are you using TDXD first line HER2 mutant metastatic disease?
I have. I mean, I think that, no cross-trial comparison, but it does look to be an active drug. The data show kind of superior response in PFS compared to platinum doublet chemotherapy, so I have done that. I do think that talking about antiemetics, we actually also do palonosetron, so like with these ADCs too, because I think preventing that nausea is really key.
So Corey, you seem more in favor of chemo IO in these patients. What's your thinking? And what does it take? We kind of have moved, it seems like, to a situation, at least observing what you all do, that when you see an objective response rate in the range of 50 to 60%, you're not doing randomized trials anymore, you're just treating. But in this situation, you're holding back. Is it the ILD?
The ILD is the main deterrent. I think if it weren't for that, I would probably make the transition. Got to remember, the PFS here is not on the order of what we're seeing with ALK inhibitors, ROS, RET, EGFR. It's about 8 months. The initial reports were much better at 14 months, but it came down. So I still use chemo first, chemo with either Pembro or some cases with Bev.
Eddie, any comments on this? And what do you do to monitor for ILD for patients on TDXD? Or most of these people are getting chest imaging, but for example, maybe they don't have disease in the chest. I mean, theoretically, the breast people are just imaging people as frequently as they can. And do you agree with Matt's approach to ILD? You'll retreat if it's asymptomatic and maybe not if it's symptomatic.
So I have retreated when it's asymptomatic. The rules of these studies are often very restrictive, so we frankly don't have a lot of great data on treating these patients. As you see, in one of these questions, I've generally reserved it for second line. So in that case, my options are not so great, and I think that probably colors that decision a lot. I think that's a harder decision if you early on were to have a pneumonitis that's either not symptomatic or you're not sure if it's symptomatic, and you're in a first-line setting. I think that's a more difficult time to make a decision about whether you're going to stop and never go back to it.
All right, let's talk a little bit about KRAS G12C. We got a couple alternatives. Here's what the faculty had to say.
KRAS G12C, first-line therapy.
For now, chemoimmunotherapy. We know that patients with KRAS G12C mutations are immunogenic, and so there is even a little bit more benefit we can hope for those patients.
So choice of targeted therapy.
ADA or SOTO for now. I think if there's known CNS disease, I think the data with adagrasib has been stronger to date.
Tolerability issues with either one of these.
GI tox is significant. My experience is that it's greater with adagrasib because you dose it twice a day. I think adagrasib has a little bump in creatinine, as well as, we look for transaminase elevation with both.
It's more a judgment call on what toxicity the patients feel they can tolerate. SOTO, hepatotoxicity, ADA, GI, nausea, vomiting, diarrhea.
Helena, what are your thoughts about KRAS G12C? What do you do first line, and which agent do you go to?
Yeah, I agree. I kind of have equipoise between the two options. Definitely, I agree with Melissa, chemo IO as first-line treatment, and then sotorasib just from familiarity.
Any comments on what you observed in terms of tolerability with the two agents?
Yeah, I don't find them to be so different. I do think that the GI tox is there. I do have to dose reduce, a subset of patients, but I don't think one versus the other.
Corey?
This class of drug, particularly sotorasib, is far better tolerated than anything we have for MET or BRAF. I mean, it's exponentially different.
When what is your issue in terms of tolerance of BRAF? What do you see?
Fever, rash, edema. Often had to interrupt doses or dose reduce. Sotorasib, I've been able to give full dose to the majority of my patients.
David?
I agree with Corey in general. We'll talk about MET inhibitors. The one thing you have to be careful about, because everybody, I think, agrees chemo IO first line, is there's been some data of hepatic toxicity when you start sotorasib too soon. I think it was 12 weeks in the last data set I saw from your IO therapy. That doesn't seem to be true with adagrasib. So since everybody's coming off IO, and you've just told your patient they have progressive disease and you want to start something, there's some concern there about hepatic toxicity.
And we'll get into this later when I ask the question of our virtual faculty, what do they do with a really sick patient who's got a high PD-1, but you don't have back your NGS? And it really gets into this issue of when, we heard about the idea of post-IO toxicity with osimertinib. It sounds like you all really buy into that. But then what about everything else, all the other TKIs? How much data do we have on that? You just mentioned KRAS G12C. What about RET, some of the other inhibitors shortly after IO?
Yeah, I mean, we know some data from a study before, I think the Tatton study, that suggested there was more toxicity than we expected. Eddie and I have been part of some trials, certainly with the ALK inhibitors. Do not do that. That's quite dangerous for the liver. Not so true, though, with some of the other areas like MET and RAF, as you mentioned.
TDXD?
With TDXD?
Yeah.
And IO?
Yeah.
It's being done. Obviously, it's in lung cancer. It's in still early studies right now. It's being done. I've done it off study, but I know we're waiting for more data.
So, Eddie, I'd like you to respond to the virtual faculty's thought about management of patients with MET exon 14. Let's talk about MET. Again, preferred first-line therapy?
Chemo-immuno.
Second-line therapy?
Tepotinib, because it's once a day.
Checkpoint inhibitor?
For MET, I would probably think twice about it, because you're going to give a TKI second, and I know that. And so it's the immunotherapy first and the TKI second where you run into trouble. So I would think twice.
From your point of view, in terms of not wanting to have an IO recently, do you think that applies to all the TKIs or just to some of them?
I think it probably applies even more than we realize.
So, Eddie, any thoughts?
So I think that this toxicity that you get after IO is real, but on the other hand, I think like anything else, you have to weigh the pluses and the minuses. I think one of the things that becomes problematic here is when you talk to the patient about what they want, generally they want a durable response. They want the sort of response that we've associated with immunotherapy. And in some cases like RET, ALK, we have good data that they're not going to be able to get that in most cases. So we don't consider that a real trade-off. I'm still not sure we have that data in MET, and we do know, in fact, that we all have some patients in our clinics that have had long-term responses with these agents. So I think the risk of toxicity is real. On the other hand, the tolerability of these agents is okay, but not great. I think that the durability of response, again, is okay and not great. And so my bias has been to look at chemoimmunotherapy in many of the patients in this setting.
What about your choice of first-line therapy?
I'm probably a little bit biased just in the sense that we participated in the registration study for capmatinib, so I have great familiarity with it. The two things that I would say, and I think this is probably across the class, one, I think if you have someone in their mid to late 80s, which we see a lot, the median age for these MET exon 14 skipping is in their 70s. I think it's unlikely that those people are going to be able to tolerate full dose, and I've generally started even at a lower dose. The other thing is that the edema is a real problem, and the one thing that I do instruct patients, I have a lot of patients where I am sort of their second oncologist, and the one thing that I try is I set a limit. I say, don't let anyone put you on more Lasix than maybe 40 milligrams a day. My preference would be that they don't go on Lasix at all. I don't think it works, but I never win on that one because they're swollen and somebody wants to give them Lasix. So I've tried to give them a cut point because I've had a lot of syncope events and things like that, renal dysfunction from a supportive medicine that doesn't work.
John, you had a thought?
Yeah, I guess this is one where I disagree with Melissa. I'm usually reasonably aligned, but here if you've got two approved TKIs. You've got capmatinib and tepotinib are both approved, and this is if there's parity, you could debate this, but the PFS, you know, first of all, the response rate in the first-line setting is much higher than for chemotherapy. Chemotherapy in this setting, you expect 25 to 30% response rate. For both drugs in the first-line setting, the response rate is north of 60%. PFS is north of 10 to 12 months in the first-line setting. For chemo, you expect about 5 months. So for me, it's TKI in the first-line setting with MET. And, you know, I think the interaction with immunotherapy really is going to be idiosyncratic and is not TKI overall. You know, I think in lung cancer, we sometimes forget there's plenty of TKIs that get combined with immunotherapy all the time. In kidney cancer, you do it all the time. In lung, we see drugs like sitravatinib get combined, you know, or axitinib, it gets combined. So you can combine them, but there really are certain ones that have these negative interactions. I wouldn't make this a TKI class, so I'd start with TKI. The last thing is, I agree. Everybody puts patients on Lasix. They often get hypokalemic. If that happens, they get syncopal. I don't know that spironolactone helps, but at least they don't get hypokalemic if it's potassium sparing. You know, people can tolerate spironolactone, so I end up using that instead.
So David, let's have you review some of the data.
Yeah, sure. I do use both Lasix and aldactone together, and they don't work. Okay, so this just came out. Corey had some great slides as well to show the frequency. I just want to point out a couple of things. One, when we talk about MET alterations, specifically exon 14, it's probably the best reason to test squamous patients in terms of comprehensive NGS testing. You often hear people only say adenocarcinoma. You know, I think everyone up here will test every histology, but you know, you can see exon 14s in squamous cancers. We'll go through this in a little bit more detail. It's still low. Less than 5% of patients are going to have exon 14 mutations, and I'll talk to you about immunohistochemistry in terms of MET expression. You know, that varies, right, in terms of what's high expression in different patient populations. That might be anywhere from 20 to 40%, some say 60%. We know amplification of MET is very low, so high amplification is less than 10%. And the other thing I want to point out is KRAS mutations. In this pie chart, it shows 23%. 12C mutations are the most common. There'll be about 10 to 15% of our KRAS of adenocarcinomas will be KRAS 12C, so a pretty sizable population that we see. And then HER2 mutations are quite rare, you know, probably less than 2%. So this is, I just pulled this. It's kind of fun seeing what changes with NCCN. So this is kind of all the things we're supposed to be testing for. There's 10 different targets here if you count PDL1, so that number keeps growing. And then, you know, these kind of follow-up pages in NCCN, they kind of suggest you may want to look at MET amplification, although capmatinib and tepotinib is only approved in the exon 14 setting, but I'll show you data that it can be used in the amplified setting. This is another interesting finding just before we dive into this. You know, we talk about NGS testing, liquid and solid tumors. We get tissue testing, we get liquid testing, but this RNA difference is really impressive. And so you'll see some vendors out there kind of say, well, we offer RNA testing and other vendors only offer DNA alone. And you can see there is some discrepancy, particularly with fusions. And a lot has been made about this in terms of which vendor can find fusions better than others. It's probably small numbers in terms of discrepancy, but there is some difference here. And it's why you're seeing more people talk about getting RNA, particularly when you're looking for alterations in lung cancer. Okay, let me just go through capmatinib. This is a study Eddie was involved in. This was published in the New England Journal. In fact, every alteration here I'll show you was in the New England Journal. And these are all basically studies in refractory non-small cell lung cancer. This study was interesting in that it included patients with exon 14 mutations as well as MET amplified, and you can see the gene copy number cutoffs there. And just to dive into the data here, so John is correct that the response rates kind of depended how heavily pretreated you were. So if you had 2 or more prior lines of therapy and you had an exon 14 mutation, the response rate was about 40%. But if you were newly diagnosed, the response rate was close to 70% in the first line setting. Pretty impressive. They did look at patients who had gene copy number. If your gene copy number was less than 10, your chance of responding was less than 10%. But if your gene copy number was higher than 10, you had a response rate that approached about 20 to 30%. That number was even higher if you were newly diagnosed, about 40%. So a good argument why amplified made NCCN recommendations. Everyone's kind of touched on this, a complicated slide, but edema is the problem. It's a nightmare for patients, and I've had patients, despite having no evidence of cancer, after a year or two, just decide they have to stop. They just can't keep living like that. We have to solve this problem. It's a great efficacy story, but the toxicity is a real nuisance for patients. So tepotinib's the other kind of major breakthrough that's got approved just after CAP. So same idea, heavily pretreated patients here. A little bit of a complicated analysis, but in short, the response rates were about 41%, so the same data. There were some patients here who had amplified tumors, but they don't really tell us. You can look in the subset, in the appendices, but there's not really reported data on those patients. There's been subsequent breakdowns of those patients. In short, this drug has the same efficacy in terms of capmatinib in a refractory patient population. And then just to show you here some of the safety issues, it's identical, it's edema. And you guys have these slides. The other drug that's kind of on the horizon, of course, is some of the novel ADCs. So this is Teliso-V. This is an antibody that targets METs and ADC with that MMAE payload. We're seeing some early data here. Just know that there's still more work to kind of come out of this to see if this is a drug that's going to work, not in exon 14 patients, but in highly expressed patients or in amplified patients. Could be another story, another option for patients in a refractory setting. To move to HER2, so we kind of know these data well now. Bob Lee published this out of Sloan Kettering. This was a great study. This was the Destiny-01 study, and so this was looking at patients with refractory HER2 mutated non-small cell lung cancer. High response rate here, approaching 40 to 50%. This was a very favorable trial. The problem here was the toxicity, and it's actually not even shown in the toxicity table in the New England Journal. So you have myelosuppression, you have some GI toxicity. So it's interstitial lung disease. So the rate was about 25%. And there were 2 patients who actually died as a result of that. So that's caused some concern, of course. This was at a dose of 6.4 milligrams per kilogram every 3 weeks. And this is another part of that study looking at the HER2 overexpressed population who didn't quite have that benefit that the mutated patients had. But then Destiny-Lung-02 was a follow-up study to Destiny-01 to look at different dose levels. And so on the left there is the 5.4 mg per kg, small numbers here. And then on the right is the dose from the Bob Lee paper that was published. You can see the ILD rate here is lower. Sorry, it's on the next slide. I apologize. Is lower here. So if you look at these rates here, this doesn't look like kind of what was published in the New England Journal paper at 6.4, but suffice to say the 5.4 dose looks to be much safer. And I think a lot of doctors are leaning towards that. I know in breast cancer, there's kind of a lot more experience and comfort with different dose levels, and even in GI malignancies, but we're not quite there in lung cancer. So to finish up with KRAS, not much to say here that you all don't know. We have 2 drugs, FDA approved, sotorasib, adagrasib, very similar studies, refractory patient populations with G12C mutations, response rates that approach 40 to 50%. We have durations of response that approach anywhere from about 9 to 11 months, and some GI toxicities, as you've heard here. These drugs, have been approved because they've been compared, in the case of sotorasib and CodeBreak 200 versus the standard of care docetaxel. So I'll just kind of leave it at that because we've been through these data and we're in the last minute here. But let me just say that we now have standard therapies for MET alterations. Right now it's exon 14. I showed you some data with amplified. We don't have any approved strategy for MET overexpressed, but ADCs are being developed to look at that population. KRAS 12C right now, many drugs in development for the other G12D, G13V alterations. And HER2, the approval right now is in this narrow population of mutated patients, but hopefully, like in the other malignancies, breast and GI, we will see data and comfort in using these in highly amplified or highly overexpressed patients, and maybe one day low-expressed patients like in breast cancer. We'll just say that comprehensive NGS testing, I think it's kind of silly to keep saying this, but it seems like the data suggests we need to keep describing the importance of testing broadly in both adeno and squamous lung cancer in every patient who has advanced disease because of these and other markers. And then I would just say watch out for the antibody-drug conjugates. Those are looking very promising, certainly in the refractory setting in these same populations.
Yeah, you guys need some more antibody drug conjugates. We're seeing them all over oncology. David, real quick case sent in from the audience. Patient with MET exon 14 skipping mutation, initially presented with brain mets, undergoes resection, treated with capmatinib. 8 months later, the patient has systemic progression, goes on chemo. Would you continue the capmatinib or stop?
So I've done that, but I look for reasons to stop capmatinib. It's I think it kind of depends what's going on. That patient probably is struggling with pretty bad edema, peripheral edema, and I think we could probably control their progression with chemotherapy, maybe IO as well, and then radiation.
All right, well, let's go on in a few minutes. Eddie is going to talk about the approach to first-line therapy, particularly the issue of immunotherapy in patients without targetable mutations. But again, we're going to start out, and I'll ask Ticiana to respond to these first comments from our virtual faculty.
Even in a smoking adenocarcinoma patient who is in trouble, I would still be very reluctant to give an immunotherapy straight away. I would just be worried that it would box me in if this very sick patient a week later I found would benefit from a MET inhibitor, from a RET inhibitor or the like. So I would still be pretty dogmatic about holding the first dose IO. Even if I have to introduce it a week later off cycle, that might be my approach. I think pushing the issue to that squamous patient who does have a heavy smoking history, who is older in age, that's a patient where, especially if I have a high PD-L1, I might be willing to say the pretest probability is so low of something that would be better or would be a toxicity issue. That's a patient I might be willing to pull the trigger on immunotherapy for.
So I should have explained, Ticiana, what I was asking about is a patient who presents with metastatic disease, extremely sick, needs to be treated right away. Maybe you have a PD-1 level that's high, but you don't have the NGS. And the question is, are you going to give an IO or not in this situation? Sounds like not to me.
Yeah, I think this is an easy one for me. For a non-squamous patient that is highly symptomatic, that the NGS is not back yet, certainly that is a patient that I will do a concurrent approach of liquid biopsy plus tumor tissue NGS, because you get the results back in 10 days. I would initiate chemotherapy with platinum pemetrexed and wait for the NGS results. For the squamous non-small cell lung cancer, I feel very comfortable. Even with the PD-L1 high, given the highly symptomatic patient, I would certainly do chemoimmunotherapy in that setting, given a more rapid response and a deeper response with combination strategy.
Yeah, we were asking that question for a long time, and then we came up with the idea, okay, well, let's, again, the patient is really sick, and we said, well, let's ask them if they're a smoker or if they have squamous, maybe, and you can see just by changing that variable, the approach changes. So again, we'll go back to our virtual faculty again in terms of some of the key questions that come up in first-line therapy.
Let's talk about immunotherapy in the metastatic setting with patients without targetable mutations. Do you have any preference for IOs if they have IPD-1?
Not really. Of the 3 approved agents, I have complete equipoise. I think that if push came to shove for insurance reasons or patient preference reasons, for whatever reason, I would feel comfortable with any of them pretty equally.
What will get you to use chemo plus IO in a patient with a high PD-1? And does it make any difference whether it's 50% or 95%?
Doesn't make a difference to me, the percentage. In fact, sometimes the higher the percentage, the more skeptical I am. It doesn't take much for me to add chemo to immunotherapy for those PD-L1 high patients, because these patients don't always do great with monotherapy PD-1. Many times.
You ever think about the strategy of starting out with the IO and then maybe adding the chemo after if they're not doing well?
Yes, like borrowing from the melanoma strategy of adding the ICP. That makes sense to me. Although I will say that what does push me to use chemo is any symptom, any disease-related lung cancer symptom. And so that pushes me to use it from the beginning.
So I'm curious, John, we were talking this morning about tislelizumab, and supposedly slightly different mechanism of action. You have Dr. Allison there, the father of checkpoint inhibitors. Any thoughts about whether there's any you can tease out any difference either in efficacy, John, or tolerability? And do you go along with Matt's view that whatever he can access, he's fine with?
Yeah, I agree there. I think there was a period of time where certain studies came out and we said, boy, this looks consistently better than that. And then a different disease setting comes out and they sort of flip. You give an example, early studies where Pembro looked the best, and then we look in small cell and you say, boy, Durva or Atezo looks the best. I have equal poise with all of them. I think the more challenging question is who you add CTLA-4 inhibitors for, and that's a sort of different set of issues, but I think that's going to be the group that isn't responding as well to PD-1.
Yeah, we're going to actually get to that in a second. Helena, though, what about, and here's the faculty's thought about difference in PD-1 inhibitors. What about the patient with a high PD-1? Sort of traditionally, we've thought about the symptomatic patient, the younger patient to get chemotherapy. In your practice, how does that actually play out? In what situations are you using chemo, high PD-1 levels, Helena?
Yeah, I completely agree with Melissa there. I think any symptoms that are related to disease, even with a high PD-L1, I would add that in. And rather than what you suggested, Neil, of adding in the chemo later, I'd be quick to back off on the chemo. So maybe, give 2 cycles and then maybe try the IO alone.
So, Corey, I'm going to be interested in your response to the faculty's comments about patients with PD-1 negative tumors. Your approach to first-line therapy of metastatic disease in people with a PD-1 of 0.
If they're very fit, I'll go for checkmate 9LA, chemotherapy with ipi/nivo, 4-drug combination. That appears to have the best outcomes in the PD-L1 negatives. If they are not as physically robust, either based on age, comorbidity, whatever, I'll go simple Keynote 189 or Keynote 407, depending on the histology.
Any thoughts about the differences in efficacy and tolerability of durva/tremi versus ipi/nivo, at least the way they've been used?
No, I think the tolerability is very similar.
I'm increasingly having conversations about nivo/ipi, either alone and with chemotherapy, or even now with the newer data, durva/tremi, though I haven't given it. I think that this kind of intriguing subset of PD-L1 non-expressing tumors having maybe outsized benefit, I think has kind of been interesting.
So, Corey, any thoughts tomorrow morning when we talk about hepatocellular cancer? We're going to talk about durva/tremi there, which is an alternative to atezo/bev in the first line. They give it differently than they only give 1 dose of the tremelimumab. First of all, what are your thoughts about PD negative patients in general?
So for PD-L1 negative, it's been basically histology appropriate chemo plus Pembro, Keynote 189 or 407. I would have equipoise comparing that approach to 227 ipi/nivo, ipi/nivo chemo, or the Poseidon approach. Poseidon is basically 9LA with the chemo continued beyond 2 cycles to 4 cycles and ongoing. With the platinum shortages, ipi/nivo becomes a bit more attractive.
David, any thoughts about this? I know in the beginning there was a lot of pushback, when people brought up the issue initially of ipi/nivo, and now, as Corey was saying, with durva/tremi, but I'm hearing more and more people talk about that. What's your approach, David?
Yeah, I agree with Corey. I did start using 9LA in the zeros right when that got approved, but I haven't seen what the papers suggest you should see. So I don't think it's any better to me than Pembro.
John, interestingly, you say durva/tremi plus chemo. Why is that?
Yeah, and I would have equipoise with 9LA here as well. But, I think the data is supporting that adding tremi certainly doesn't help in the greater than 50%, or adding CTLA-4 in general. But really these lower PD-L1s, and particularly those with either STK11 or KEAP mutants that we know are very resistant, that seems to be where adding either ipi or tremi makes a big difference. Here I'd have equipoise with Poseidon or 9LA, but I try to avoid, certainly I try to make sure that CTLA-4 is included for PD-L1 zeros, especially if they've got those bad mutations.
It looked like the way durva/tremi was used in HCC, indirectly it looked like they had less need for corticosteroids than ipi/nivo. Again, indirect comparison. Melissa thought, I think it was Melissa who mentioned, she thought they were about the same in terms of tolerability. Of course, everybody's concerned about CTLA-4. From your point of view, are they both about the same?
Yeah, well, it's interesting because in the 9LA regimen, you keep the CTLA-4 going forever. In the Poseidon regimen, you stop it right after the 5th cycle, but you keep the maintenance chemo going forever. So I think, we have some people where their adverse events are related to CTLA-4, others related to the chemo. I don't see a major difference in tolerability between the two. But if we're having immune-related adverse events, I'm quick to stop the CTLA-4 because you may not need it indefinitely.
So, Helen, I'm curious about your thoughts about Jaruska's comment. I wanted to ask her about a couple issues that she's been very involved with in terms of research related to checkpoint inhibitors. One is this thing that you hear in many different solid tumors about the question of whether antibiotic usage is any way correlated with outcome with checkpoint inhibitors. And also, again, the question that's been out there a long time, Jaruska has done a lot of research on this, about whether or not if you see autoimmune toxicity, more likely to benefit. Here are her thoughts.
I'm not sure if the use of antibiotics is simply a surrogate for performance status. The answer so far for me is no. I don't think there's any hard data to say what the time interval is that you should avoid antibiotics, what antibiotic is of relevance or not. Obviously it's microbiota, but which antibiotics, when, how. So I don't change anything just yet.
So what about the relationship between autoimmune toxicity and efficacy in general, but also specific to different toxicities?
Yeah, so obviously this is my area of research. So skin toxicity appears to be associated with greater benefit from IO, and pneumonitis is associated with worse outcome.
So just kind of curious, Helena, do you try to avoid antibiotics in people on IOs? If you see people who have autoimmune toxicity, do you think to yourself, maybe they're going to have a better response?
I think it's hard to avoid antibiotics. I think if it's clinically appropriate, I'll give it. But I think I was one of the people that said, I think there's increasing data that like a healthy microbiome definitely contributes to immune response. So, I think it could be better to not, but obviously you do what's clinically appropriate. And I absolutely think that there is a clear relationship between autoimmune toxicity and treatment benefit. I think all of us are, likely have a patient or two who had something horrible skin, immune-related toxicity. You stop the IO, and 2 years later, they're still have excellent disease control. So there's something there.
It's interesting how when you ask the same question over the years, sometimes the answer changes. Wasn't that long ago that I didn't see anybody answering yes. Now almost everybody answered yes. Eddie, I noticed also you were in the antibiotic fold also. What are you thinking?
So I think this may be that I don't conceptually disagree, but the way the question was asked. So I think the answer is, do I think people with antibiotics before their immune checkpoint inhibitors do worse? The answer is I absolutely do. Do I think it's because of the antibiotics? I agree with Jaruska. I think that the fact that they're getting antibiotics indicates that there's something that's more concerning. So I'm not as sold on the mechanism.
Have any thoughts about the skin thing that she mentioned? I hadn't heard that, but skin specifically being predictive?
So I think the skin is one thing. So Aaron Lisberg in our group actually published this from the original Keynote 001 Pembro experience. And we did see an increased likelihood of benefit in patients really across different toxicities. The one thing that you have to realize, though, when one looks at that data, is it's heavily confounded by the fact that people who are on a drug longer are more likely to experience toxicity. Because if you are on a study and you stay on a drug for 2 months and then you progress, you go off, and particularly with when these toxicities hit, you're generally not on long enough. So I think that there are good quality studies. I think ours was good, looked at some of these confounders and still did find that there is some improvement, but it's not as marked an improvement as if you don't adjust for the duration of time on therapy.
So before you start going through the data, just to come back to you, John, again, one of the things that we've talked about over the years, we talk about it anytime we talk about checkpoint inhibitors, is relative contraindications, prior autoimmune disease, and prior transplant. I'm curious how you think that through, both in the adjuvant setting as well and as opposed to the metastatic setting. What will get you to back off an IO? What kind of multiple sclerosis, treatment? You hear different things. For practical purposes, how do you approach it, John?
Yeah, I've become more aggressive when people have non-life-threatening autoimmune conditions. Mark Awad helped assemble a big data set with people who had arthritis, psoriasis, conditions like that. And it did get worse with immunotherapy very often, but it was always manageable. Nobody had life-threatening complications, and they still responded. So for non-life-threatening things like that, I'm comfortable trying it. I explain to patients, we'll give it a shot. The things that scare me out of it are things like lupus, CNS autoimmune conditions, history of Guillain-Barré, I had one patient, and transplant. Now, I don't have a data set where I've had patients that went south who had a transplant that got it. I'm just afraid to try it, So the things that are potentially life-threatening like that are where I sort of draw the line.
Yeah, we were at the AUA meeting a few weeks ago, and there we saw a number of cases of patients with renal transplant, which again is a little bit different than heart transplant or hepatic transplant. In any event, Eddie, we asked you to go through some of the data related to this.
Sure, so I'll quickly go through current management of metastatic non-small cell lung cancer without a targetable mutation. Obviously one option is upfront single agent therapy in patients who have high PD-L1 expression, 50% or greater. This was originally approved as part of the KEYNOTE-024 study. This study did allow crossover, but nonetheless did have a very profound improvement in progression-free survival and overall survival when pembrolizumab in red was compared to chemotherapy in blue among these patients with high PD-L1 expression. There are now two other approved data sets. The EMPOWER-1 study, which you see here looking at cemiplimab, and the IMpower-110 study, which is of atezolizumab. When I answer this question, I list that I would have equipoise between cemiplimab and pembrolizumab. I do have some concerns. If you look at the 3-year outcomes from the IMpower-110 study, the significance is lost by 3 years. And although I always explain to my fellow, if you follow people long enough, we'll all be dead, that my sense is that 3 years I would have expected to see that hold up. And knowing that we have two other data sets where we did, I do have some preference towards that. Just to note that the KEYNOTE-042 study also had a large population of patients who had high PD-L1 expression. And interestingly, that data wasn't quite as impressive as the KEYNOTE-024. So I think it's just important to note that when comparing pembrolizumab to other agents. Obviously, PD-L1, which has been our basis, is not our only biomarker. This is from the original tumor mutation burden paper by Nair Rizvi. He took samples from Memorial as well as some of ours from UCLA. From pembrolizumab-treated patients to evaluate whether or not they did better if they had a high tumor mutation burden. And in green, I think the lower right panel is the easiest to see, they clearly did better. There tends to be, this is a little bit hard to interpret, but from the lung map, a study where they basically looked at the hazard ratio versus sort of standard therapy. And what you can see is that in reality, I think there's a group of patients who have pretty low tumor mutation burden that don't derive much benefit in red here, and a group with very high who derive significant benefit. It's hard to know whether it's a really helpful marker outside of that. And from work out of MD Anderson originally, we're starting to have some of these relative predictors, STK11, for instance, which is something that sort of makes us concerned about the potential benefits of single agent PD-1. But in the end, most of us don't make treatment decisions based on that alone. There is an approval, of course, for patients with 1 to 49% PD-L1 expression based on KEYNOTE-042. As you can see in this group of patients, survival was really pretty much equivalent between pembrolizumab and chemotherapy in this population. It's important to note that this patient had a very low rate of crossover. So this doesn't apply entirely to a group in the United States who generally would have had the opportunity to receive pembrolizumab at a later time point as well. The Checkmate 227 study, I think this is for someone who doesn't follow this literature closely, one of the more difficult ones to follow. It's a somewhat difficult study design, but patients who had PD-L1 expression were randomized to nivolumab, ipilimumab versus chemo versus nivolumab, and they didn't have a nivo alone arm in those who are PD-L1 less than 1%. It was nivo-ipi versus chemo versus nivo-chemo. And the statistical analyses were versus chemo. One thing that is difficult is when they actually submitted for approval of this, they had to choose the population that they wanted to get approval in based on where they thought they would have their best data, and that was in patients who had PD-L1 positive disease. And you can see the data here that nivolumab plus ipilimumab really looked the best, and that becomes even more true over time. It was true particularly in non-squamous disease with respect to the nivo alone arm, and clearly true versus chemo in both of the arms. One thing to note, though, at least of patients who have high PD-L1 expression, there was a study of pembrolizumab with or without ipilimumab, and that study actually was closed early for futility. The hazard ratio for the combination arm in that case actually showing a hazard ratio over 1. Interestingly, although the study was submitted for approval for patients who had PD-L1 expression of 1% or greater, and that's where the FDA approval lies, one might argue that the strongest data actually is in these patients who have PD-L1 less than 1%. Here you can see the blue line for nivolumab plus ipilimumab versus nivolumab plus chemotherapy, and chemotherapy in green. One question people may say, well, if you have this nivolumab plus chemotherapy versus nivolumab plus chemotherapy, why are people still using, for instance, the Keynote 189 regimen? Of course, nivolumab plus chemotherapy is not an approved regimen and did not succeed in its phase 3 trial. The Keynote 189 you saw us refer to frequently when we had our discussion. This added pembrolizumab to chemotherapy versus chemotherapy alone, and benefit was seen. Magnitude was greatest in patients with high PD-L1, but was seen in patients with low or no PD-L1 expression as well. And this data is very similar in the MPower Lung 3, which basically is a similar study combining the histologies. There's a separate study in pembrolizumab of squamous disease. Here, squamous and non-squamous is combined, and you can see that the combination of cemiplimab and chemotherapy is better than placebo and chemotherapy as well. One regimen that is available, but I think probably not used that much, it's a lot of drugs and takes a lot of time for the patient, but adds atezolizumab to bevacizumab, carboplatin, and paclitaxel. Some of us use this in some settings in EGFR mutation-positive patients, but in general it is an option that can be used, and many people have already discussed the Checkmate 9LA study. This study looks at nivolumab, ipilimumab, and chemotherapy with an abbreviated course, only 2 cycles of chemotherapy, compares to chemotherapy alone. And you can see the 3-year update. On the left, you can see the PD-L1 greater than 1. On the right, you can see the PD-L1 less than 1. In both of these cases, it is better than chemotherapy. One of the things that is very difficult for all of us in this situation, of course, is that we're forced to sort of do what we always then tell people not to do, which is to try and do cross-trial comparisons and try and make your treatment decisions. And I think it is very difficult. Each study is slightly different. The Poseidon is probably the newest approval here, and that is has also been mentioned. Durvalumab and chemotherapy was compared to durvalumab tremelimumab and chemotherapy. Actually both combinations. So durvalumab and chemotherapy were compared to platinum-based chemotherapy. Durvalumab tremelimumab and chemotherapy were compared to platinum-based chemotherapy. And in fact, the only one of the arms that was a winner there was durvalumab tremelimumab and chemotherapy. Here you can see the progression-free survival curves on the left, as well as the overall survival curves on the right, both favoring durvalumab tremelimumab along with chemotherapy. There are some efforts now to look at subsets of patients who are felt to have worse predictors. Here you can see, just like the PD-L1 negative group, some people have become enthusiastic about the combinations with CTLA-4 inhibition. The same is true here in the setting of mutations of STK11. I think that in the interest of time, I'll stop here and just list that monotherapy options include pembrolizumab in patients with 1% or greater staining for PD-L1, pembrolizumab, cemiplimab, or atezolizumab at that 50% cut point. Nivolumab plus ipilimumab is approved in PD-L1 positive patients, although again, arguably the best data is in those who are PD-L1 negative. Chemotherapy plus PD-1 inhibitor options include chemotherapy plus pembrolizumab or siblimumab, and there also now are 2 options for the combination of chemotherapy plus both a PD-1 or PD-L1 inhibitor and a CTLA-4 inhibitor.
So a couple questions from the audience. Helena, I think this case has your name written on it. 35-year-old woman, EGFR-mutant advanced disease, gets osimertinib, responds, then progresses. Liquid biopsy shows a BRAF mutation. Patient gets treated with combination of anti-BRAF and osimertinib. Excellent response for 6 months. And then Empower 150 response for 6 months. Now has a ROS1 mutation and no BRAF.
It's complicated, right?
Seems like it. She says, so now what? Or they say, so now what?
Yeah, I mean, I think that with these acquired alterations, one thing to point out is they're always subclonal, right? So they're in a portion of the cells, and the likelihood of response to a combination therapy depends on how much of the tumor population has it. So I find as you get farther and farther out and patients are heavily pretreated, a lot of these acquired mutations are quite subclonal. I would certainly, you've done the chemo, you've done the osimertinib. I think it would be reasonable to try. We've combined osimertinib with crizotinib, so I think that could be reasonable to try. But that would be my concern: is farther out, there's more heterogeneity.
So we're going to move on to our last module. And of course, everyone is looking forward to the presentation on Tuesday morning of Tumor Treating Fields that actually Ticiana is going to be doing. I'm so interested. I know that you're presenting like at 11 or something, but the abstract's coming out at 7. I'm going to be ready at 7 to see what that hazard rate is, because I think everybody really is fascinated. We've talked about Tumor Treating Fields in the past with glioblastoma and then mesothelioma. Now there are trials. We were talking about at this SGO meeting, or trials combining with paclitaxel in ovarian cancer. And this paper that you're about to present, I think there are a lot of people of interest. Here's some of the thoughts from the faculty.
Tumor Treating Fields is obviously something that has been around for glioblastoma multiforme and other tumor types. My understanding is that it's quite a technological commitment. It involves a lot of sort of practical nursing care to place the device. If there's benefit, we can figure it out, but I think it is a very full-on medical device. And I think if that is going to come to the fore for lung cancer or common cancers, there needs to be significant infrastructure to enable it to be delivered. Obviously, there appears to be a signal in the data. Where to fit that in, how to contrast that with a traditional systemic therapy, I think that those will be the practical challenges in our field.
I think that's going to be one of the more interesting things at ASCO. I'm very much looking forward to a rigorous phase 3 trial and to see what the magnitude of benefit is. I think talking to other investigators, we're still a little unclear exactly how this mechanism works, but to their credit, randomized phase 3 trial, let's see what it looks like, especially in that second line and beyond setting where our other options are more sparse. I'm willing to do things that I may not understand as well, right? If they really show in this rigorous trial a strong hazard ratio, I'll have to look into it more.
Any thoughts about where data is going to fit in your treatment plan in the future?
I think it will be approved in the second line. I think the Tropion Lung 01 trial stands a good chance of being positive. And so in the Tropion Lung 1 trial, it was patients in the second line after chemoimmunotherapy. So that's a big wide open space where now we'll use Dato in lieu of docetaxel. I think the other hot button question is whether it will then translate as well into the front line.
So, John, we were doing a program on ovarian cancer, and one of the things we wanted to get into was Tumor Treating Fields, and I couldn't find any of the investigators who really could explain the mechanism to me. I actually started looking in the literature. I don't know if you've heard of Chirag Patel at John's Place, a neuro-oncologist. He had these incredible papers on the translational science behind Tumor Treating Fields. We actually brought him onto a webinar just to try to explain it to us. Any thoughts about this, John?
Yeah, I should go 2 floors down and have him explain it to me then, if he gives such a good explanation. I've got nothing here, to be honest. I'm right there with Matt. It just intuitively, it's not ringing a bell, but to their credit, they're doing a proper study. And if they do a proper study and it's robust and it shows a hazard ratio that's impressive, I think we want to listen to the data even if we don't understand it fully. But I don't have predictions or insights into the data here.
David, I'm curious. It's interesting to me. I love the idea it's different. I think maybe we need more things. I mean, it is exciting what's going on with the therapies we have, but I like the idea of something different. Any thoughts about this? And also Jarushka's issue about what's it going to be like? I mean, hopefully there's only one person here who really knows the answer, but if we really do see some effect, this is going to be changing the face of the oncology waiting room.
Yeah, and I think, a lot of the audience is familiar with the glioma data. It's been compelling, and it's what patients want. In that setting, it's 18 hours a day. But you're talking about a setting where there's just not a lot else to offer patients. Might be different in lung cancer, and I think she brings up a good point. What I understand in the CNS world is you have this amazing support team from the company that comes and helps set it up for patients. Can you do that for patients across the country with non-small cell lung cancer? That'll be tough. I do think we have this low hurdle of docetaxel to get over, and so we're all kind of interested in finding something different. And the last thing I'll say about it, at our center, I told some folks here, we have a trial in pancreatic cancer that is just enrolling like crazy with this, and patients seem to manage it on that trial. So yeah, I can't wait to see the data. Congratulations.
Yeah, I mean, docetaxel is no walk in the park at all. I'm not sure what I'd rather do, wear this vest 18 hours a day or take docetaxel. Corey? Or that may not
David
be true.
said that docetaxel is a low hurdle, except it's been 7 years. 7 lean years where we've yet to see any approach on the second line best docetaxel. Remember, it was the immunotherapy data, OAK, the keynote studies, Checkmate 17, Checkmate 57, all of which showed benefits for immunotherapy. And since that time, there have been no positive trials. So really, this is the first positive trial in that setting.
It's interesting. We asked the faculty to rate their understanding of the translational science, and you can see, most people are very upfront with us that, they don't, even when you read all of Dr. Patel's paper, I still found it challenging. Also interesting, I guess this is maybe based on the perception of how much of a hassle it's going to be, but when we ask people what kind of hazard rate for survival would get you to start thinking about something, and not that high. I know you can't talk about the data, Ticiana, but I'm curious what your thoughts are about the potential clinical issues about doing this in the clinic in terms of the kind of support that's going to be needed.
Right. So I think, again, this is a new treatment modality, and so it will require just education to patients and clinicians about, number one, mechanism of action, but number two, clinical usage in day-to-day practice. Again, this is going to be something that it's provided in terms of support by the company themselves. So there's 24/7. This was how it was on trial. That's how it's envisioned that if it gets approved, how it will be used. And so these are things that we're going to learn if the approval comes, and I think it's definitely doable. And I think one important thing that was brought up here is that patients want therapies that are going to help them live longer and live better. And if that's what the data shows, then I think we're going to be, again, individualizing the treatment strategy for patients, talking about the results, and making that informed decision-making discussion with our patients and letting them also chime in on what they think about it and how they can live with a device and what does that mean to them.
We did have a couple of patients on the ovarian trial, and one of the issues was dermatologic changes underneath the device, but I understand too that also can be mitigated. You take off give them a little bit of rest from what we heard. Eddie, what about Dato? You've done a lot of work on it. It looks like the faculty is ready to go second-line therapy. What are your thoughts?
Yeah, noting that what Corey said, which is that docetaxel has been firmly fixed, and for many years we've said how easy it would be to beat until we try. This is the one that I am particularly enthusiastic. If you look at the earlier phase data, the response rate is better than even the best response rate data we've seen with docetaxel. And more importantly, the duration of response is better. And so I think if that follows through, I think that The toxicities are real, and we certainly see them, but I think there is an eagerness to replace docetaxel.
Can you comment on the toxicity? Is this the one that causes the mucositis?
Yeah.
Correct. And I think that also, one of the things that, and I think in a general practice, they may be more familiar with mucositis. Obviously, there are other cancers where that's common. It's not something we're used to very frequently. And I think that hopefully supportive care measures will get better over time, but it is a challenge.
Yeah, your colleague in breast cancer, Sarah Hurwitz, was one of the ones who pioneered the swish and swallow for, I think it was everolimus in breast cancer, really for mucositis, did a great job. Well, I think with that, we'll actually ask Ticiana to go through the data.
So we'll talk about future directions in the management of metastatic non-small cell lung cancer. And to start off with, we've discussed this quite extensively here tonight about the promise and hopefully the presence in the clinic in the near future of ADCs or antibody drug conjugates. On the right, what we're seeing is sort of the different factors that have led to improved newer generations ADCs, many of them that are actually now already in clinical practice for other disease types such as breast cancer. So here's a list, a comprehensive list of the current status of ADC targets and therapeutics in non-small cell lung cancer. This is a table from the ASCO Educational Book 2023, and I put it here as a reference. If you want to read more about the targets and the development of ADCs, this is a great resource for you. And specifically thinking about TROP2 ADCs, TROP2 is a target that is highly expressed in non-small cell lung cancer. And in prior studies, we've seen that TROP2 expression is actually associated with poor prognosis. On the right here, you're seeing in adenocarcinoma, high TROP2 expression is associated with worse survival compared to no or low TROP2 expression. Currently, there is no standard way to test for TROP2, but it is identified by HC. And I think with approval, we're going to also have to think about how do we do more testing on our limited samples in frontline, beyond NGS, PD-L1, and now if we have different ADCs, different IHC tests. So that's going to be a challenge that we'll have to overcome as well. Thinking about how the development has been for Dato-DXd. So Dato-DXd is a TROP2 monoclonal antibody. It's got the component of a cleavable linker, and in addition to that, an associated potent payload, which is a topo-1 inhibitor. This study was the initial phase 1 dose escalation and expansion study. It's the TROPION-PanTumor01 study that included patients with relapsed refractory non-small cell lung cancer. Of note, patients were unselected for TROP2 expression. And then in the dose escalation, they started at 0.27 to 10 mg per kg. And we have here 3 doses that were selected for dose expansion, 4, 6, and 8 mg per kg. The primary objective here was the MTD, the safety, the tolerability, and then looking at secondary objectives of efficacy. So what we saw was there was anti-tumor activity in all of the 3 cohorts evaluated in the dose expansion at 4, 6, and 8 milligram per kilogram. You see up on the top, the overall response rate was 24%, 28%, and 24% for the 4, 6, and 8 mg per kg. And importantly here, we saw some durable responses in this early phase study, including a median duration of response of 10.5 months in the cohort of 6 milligram per kilogram. The PanTumor01 AGA subset efficacy analysis is including the patients that have actionable genomic alterations. And interestingly here again, unselected TROP2 target, these are patients with AGAs, and we saw activity with Dato-DXd in patients with EGFR sensitizing mutations after OC and across other AGAs that you can see there on the right. The overall response rate here in this cohort of patients with an N of 34 is 35%. So again, promising data in an early phase study. So moving on to the TROPION-Lung02, now we're actually moving to the front line. This was the phase 1b study that was evaluating now Dato-DXd in combination with Pembro plus minus platinum chemotherapy in advanced non-small cell lung cancer without actionable mutations. And as you can see here by the eligibility, there were multiple cohorts, including patients that were previously treated, as well as patients that were treatment naive. And what we saw again here is promising activity, and importantly, tolerability that I'm not showing here, we talked about mucositis as a toxicity. The steroid solution or the mouthwashes actually are quite helpful. But looking at this strategy here with both doublets as well as triplets with Dato-DXd, what we're seeing is pretty promising strategy with frontline therapy. The doublet and the triplet have response rates here of 62% and 52% respectively. In a second-line therapy and beyond, we're seeing overall response rates of 24% and 29% with doublet and triplet respectively. So here's the Dato-DXd clinical development, which is pretty far along. We now have phase 3 studies that are actually ongoing and accruing patients globally. We have the TROPION-Lung01, which is here included with or without AGA, and this is second line versus docetaxel. We also have TROPION-Lung07, which is a phase 3 combining Pembro plus chemo plus Dato-DXd versus Pembro plus Dato-DXd versus the standard of care in patients without actionable mutations with PD-L1 50%, less than 50%. And then the next study is the TROPION-Lung08, also in phase 3, now exploring this combination of frontline Dato-DXd with pembrolizumab and PD-L1 high expressors. So these are very promising strategies that may lead Dato-DXd to clinic if these studies read out as positive in the near future. Moving forward to what we've been talking about, tumor treating fields, sort of a completely different way of treating cancer, and in this case, lung cancer specifically. Tumor treating fields are alternating electric fields that they lead to physical forces and electrically charged components of dividing cells. This has an anti-mitotic effect, and this anti-mitotic effect has downstream effects leading to immunogenic cell death, as well as then leading to a systemic anti-tumor immune response. And there's preclinical data that has been done demonstrating this, that combining TT fields with taxanes or immunotherapy has improved efficacy. On the left, what we're seeing is the combination of TT fields with paclitaxel versus paclitaxel alone has greater improvement in terms of decrease in cell viability. And on the right, what we're seeing is the combination of TT fields with anti-PD-1 therapy has greater reduction in tumor volume compared to control or either therapy alone. And this has been the basis of moving this forward to a randomized phase 3 setting. We also have a prior pilot study that investigated TT fields with pemetrexed. It was a feasibility study that demonstrated the feasibility of using TT fields with pemetrexed in a single-arm study. Now, this is a pivotal, randomized, global phase 3 study that included patients with ECOG performance status of 0 to 2 in a randomized fashion 1-to-1 to TT fields plus standard of care therapy, which included immune checkpoint inhibitors versus docetaxel, investigator's choice, versus the standard of care. Patients then were followed every 6 weeks and continued on therapy until progression. The primary endpoint here is overall survival in TT fields plus standard of care versus standard of care alone, with key secondary endpoints of PFS, overall response rate, quality of life. So what we have now are preliminary results or press release that we've seen demonstrating that the study met its primary endpoint, demonstrating a statistically significant and clinically meaningful improvement in overall survival. To kind of give you a little bit more of information just on the practical aspects of TT fields from the study, in terms of how do we do this, one important thing to kind of understand is that this is a medical device and it's not used alone. So this is used in combination with systemic therapy. So patients wear this medical device. It is applied loco-regionally with this medical device that's on the chest. You've got 2 pairs of arrays, and the recommendation is for continuous use. The target is 18 hours or longer. And then, of course, we have to provide all of the support. And again, this is not provided by the clinician, this is not provided by nurses, this is provided by the company. They have all the support technicians who actually are available to educate patients and actually provide support at home for the patient so that they can troubleshoot anything that happens. So please join our session on Tuesday morning to hear the results of this study. In addition, we're also doing and looking at other strategies with TT fields in non-small cell lung cancer, including in brain mets, in frontline, which is the Keynote B36 in combination with pembrolizumab, and also future studies are planned in patients with locally advanced non-small cell lung cancer. Talking about second line and beyond, thinking about how do we overcome IO resistance, targeting angiogenesis is a rational approach to overcome an immunosuppressive microenvironment. We know this strategy is also clinically successful in multiple tumor types, including kidney cancer, HCC, endometrial cancer. We heard about Empower 150. This is a study that was conducted through LungMap, S1800A, combining now pembrolizumab plus ramucirumab targeting VEGFR2. This is a monoclonal antibody in a randomized phase 2 study in patients who were previously treated with both platinum as well as immunotherapy. PD had to occur after or greater than 84 days of ICI, randomized 1-to-1 to investigators' choice of standard of care versus pembro-ram. This study met the primary endpoint with a median overall survival of 14.5 months versus 11.6 months with a hazard ratio of 0.69. 2/3 of the patients received docetaxel ram. And this is the next study. This is the randomized phase 3 study to confirm these results. Moving forward with other strategies to overcome resistance to immune checkpoint inhibitor, this is the Hudson Umbrella study. This was a multi-center study with multiple cohorts, as you can see here, with Group A being a biomarker-directed study, and Group B being a biomarker non-matched studies, including combinations with durvalumab. To summarize this study, the cohort that sort of stood out as the most successful cohort was a combination of AZD6738. This is an ATR inhibitor in combination with durvalumab. In this early phase study, we saw promising PFS and OS in this IO pre-treated population. And here we have now the ongoing phase 3 trial, and this is the study schema, randomization to the combination of ceralasertib plus durva versus docetaxel with the primary endpoint of overall survival. We've looked at sitravatinib, which is a TKI that hits multiple targets, including the TAM family of receptors, AXL, TYRO, MERTK, VEGFR2, again, here another strategy to overcome IO resistance. In the phase 2 study, we reported that in patients in second or third line who were previously treated with IO, we saw really promising duration of response, really promising overall survival with a median overall survival of 13.2 months. This was the Sapphire study, the confirmatory randomized phase 3 study that unfortunately we just heard recently that it did not meet its primary endpoint of overall survival. So again, a little bit about what we talked about. Although a lot of strategies may look very promising, really looking at the data, and we'll hope to hear more about it, is very important before we start using it in clinical practice. And here's just my final slide of a manuscript that we put together with other co-investigators thinking about novel strategies, potential pathways, how do we think about immunotherapy resistance, and really develop strategies that will be clinically meaningful to our patients. So the take-home messages here, Dato-DXd, a TROP2 ADC has shown promising activity as monotherapy or in combination with IO plus minus chemotherapy in non-small cell lung cancer. Randomized phase 3 studies are underway. Pembro plus RAM in patients with IO resistance advanced non-small cell lung cancer improved survival. And we're also waiting for the results of the Pragmatica study, which is underway. The combination of Citra and Nivo, although initially showed promising OS, unfortunately did not meet its primary endpoint in the phase 3. And then last, the LUNAR study demonstrated that TT fields with IO or docetaxel led to a statistically significant and clinically meaningful improvement in overall survival for patients in the advanced non-small cell lung cancer second line and beyond setting. And we look forward to seeing these results. Please join us on Tuesday at ASCO. Thank you.
So just a couple final questions. Eddie, a lot of questions about Dato. Any correlation between TROP2 expression and response? Also, a number of people bringing up sacituzumab, another antibody drug conjugate targeting TROP2, approved in breast and in bladder cancer, has it been looked at in lung?
So I'll start with the second. So sacituzumab govitecan has been evaluated in lung. Interestingly, there was a JCO article in 2017 that showed a response rate of 17%, and I think they had so many sort of promising leads that they never sort of followed up on that until recently. Now there are phase 3 studies that are looking at sacituzumab govitecan versus docetaxel, as well as other studies looking at sacituzumab govitecan. So that is an active development. With respect to datopotamab deruxtecan, I find it a mess, but the answer is that no, there's no good data to correlate TROP2 with responses. The reason I say it's a mess is that we have this very nice story to explain to patients, that we have this antibody and it targets an antigen that's on the tumor, and then it goes there, and then there's the payload and it dissociates inside the cell. And so a sophisticated patient, the first question they said is, well, do I have TROP2? They said, oh, don't worry, it doesn't matter. And they sort of look at me like I'm crazy, and I think they're probably right. So the answer is that empirically we have not seen a correlation to date with TROP2 levels, and it is very hard to explain.
And coming back on Monday night, we'll see if they can explain why TDXT causes response with HER2 low breast cancer, if it's really targeted therapy. In any event, I want to thank our faculty, thank our virtual faculty for presenting the cases. Thank you for attending. Coming back tomorrow morning, we'll talk about hepatobiliary cancers early, 6:45 tomorrow morning in this room. Be safe. Have a great night. Thanks so much, faculty.